Oh, can you hear me okay? Yes. Good evening and welcome to the Horse meeting of the 11th of January 24. And I never know when the cut-off date is, but I wish you all a Happy New Year anyway. Thank you. As it's 6:30, I'd like to start the meeting. Right, I'd just like to remind people that this meeting is being recorded and live streamed. Okay. Right, I've not actually received any apologies. But I would like to welcome Claire Dixon, who's the new Scrutiny Officer to the Council. And I'll just give you a brief introduction. I think you were going to say a few words about your role.
Thank you, Chair. Yes, so I am the new ONS Officer. I've been in post since Monday. Some of you may already know me through my previous roles in the organisation. So myself and Lucy Tricker, the other ONS officer, will be looking to review and improve the scrutiny function going forward. We'll be working closely with officers and elected members as part of providing this support. If you'd like to meet us at any point, please do make contact with us via email, telephone, and we'll arrange a mutually convenient date. And whether that's in person or Teams, completely up to you, will be available. But yes, it'll be lovely working with you all.
Thank you, Claire. If I move on to item 2, I move that the minutes of the Health and Wellbeing Overview and Scrutiny Committee held on the 2nd of November 23 be approved as a correct record. Do members agree? Yes, it's agreed. Okay. I've not received any urgent items of business under point 3. And point 4, are there any declarations of interest? I'll take that as a no. So I'll move on to item 5, Health Watch. So good evening, Kim. And do you have anything you'd like to raise at this evening's meeting?
Thank you, Chair. I haven't got anything to raise, but I just wanted to report back on something. A couple of times we've raised here the concerns around patients at certain GP surgeries having problems accessing gender realignment medications. Surgeries refused to give it to them, withdrew it, which caused lots of problems. There's a lot of work being done. We've raised it in lots of different places, and I'm really happy to report that BB have commissioned a specific service for that medication, so the patients will carry on receiving their normal primary care service at their own GP, but they will go to that service for their medication for their gender realignment, which is great because they won't get anything. It'll been stopped for a while. So that's a really, really good feedback, and they're really happy. We've spoken to all of those that raised it with us to make sure they've all been picked up, and they have so far. So it's a really good piece of work there.
Thank you, Kim. Any questions? No? Right. So I'll move on to item 6 from Mid and South Essex Trust. I'll ask Brianna Ryan and is it Nikki Abbott?
No, Nikki's not coming.
Is he not here?
No. Sorry.
Okay. So is it just you, Fiona?
So this evening I have Jamie Andrews here with me, who's going to be talking about capital backlog, and James Currell, who's going to update the committee on phlebotomy. And we were expecting maternity along, but I will cover it off if Nikki doesn't get it.
Right. So do you want to give that feedback?
Yeah, as those were the hot topics at the previous meeting, shall we start with phlebotomy?
Is that working? I haven't used this before.
Thank you, James.
Thank you. So My name's James Currell. I'm the Director of Operations for Care Group 4, so that's Specialist Support Services at Mid and South Essex Foundation Trust, one of which is pathology, and phlebotomy falls underneath that management group. You will be aware, because there's been much communication around the phlebotomy service in the south of the Essex patch, which covers obviously Southend, Castle Point, Rochford, Basildon and Thurrock, is provided by Pathology First. So it's part of a joint venture between Mid and South Essex Foundation Trust and SynLab, who are a private pathology provider. There's been a number of communications around the level of cover that's been able to be provided across our community-facing clinics. So I know we've had questions and concerns raised about equity of access and additional capacity that we can provide to ensure that obviously the relevant queues are managed in an appropriate manner. And obviously this is largely, we're talking today about obviously primary care access to community phlebotomy. We split patients out for those requiring urgent appointments or those requiring routine. So those are kind of some of the terms we'll be referring to as I update you. There's been quite a lot of focus within Pathology First around their management structures. They recognise that there have been a number of challenges about delivery of capacity over recent months, and actually we've seen some really positive engagement with them as we've worked towards a solution to try and ensure that we've got an increased capacity and better access for our local residents. So just to update you on where we provide services that are relevant, obviously, to the Thurrock area. So we have services that are developed from the following locations within Thurrock, which are all bookable by SwiftQ. So SwiftQ is an online booking platform. It also gives patients the opportunity to see where the next available appointment is, and obviously if they are willing to travel a little bit further, they can sometimes access appointments in a more timely manner. We offer appointments at the Corringham Integrated Medical and Wellbeing Centre. Those run Monday to Wednesday between 8:30 and 3:30, and there are 62 pre-booked appointments. We offer appointments at Thurrock Community Hospital Tuesday to Thursday between 7:10 and 12:45 at lunchtime, and we've recently extended that service to 15:45, so an additional 3 hours a day to try and help with demand, which has generated an extra 45 appointments per week. There is capacity at South Ockenden Health Centre, which operates 8:10 till 12 noon and 12:30 to 3:45, and that's Monday to Friday, and also at Orsett Hospital. We have 3 chairs there 5 days a week. And this service is slightly different and is provided on both an appointment and same-day queue basis. And I think it's really important to feedback that Fiona and I met with some of the Thurrock GPs this morning, and we had some really positive feedback actually from one of those GPs about improvements to access at Orsett Hospital. So we've seen appointments really, the routine booking time is now between 3 and 4 weeks, which is where it should be. So that's come down from around 6 to 8 weeks. So that's a significant improvement in the capacity that we've been able to provide. We've also been working closely with NELFT, so North East London Foundation Trust, who also provide phlebotomy services to the Thurrock community. And again, we're working closely with them to ensure that actually we can maximise the offer and arrangements between the two providers to ensure that patients have significant access. I think probably those are the headlines around where we are now. So we've seen an improvement to 3 to 4 weeks for a routine booking. But again, there are, depending on the location, there are appointments available sooner, and obviously patients are able to see that and make a decision about whether they would prefer to travel for an earlier appointment or actually whether they remain local and it suits their requirements for travel. Happy to take any questions.
I would just add, Chair, if that's okay, so Reg Rahal, who's one of our local GPs, in particular thanked the phlebotomy team today, and he highlighted that on his last check there were appointments available the next day at Orsett Hospital for his patients, and that's come from 2 weeks down to next day. It's not next day, or it's not within 2 weeks at every site, and that's the objective that the team are working towards, so still a way to go.
Okay, thank you, James, and thank you, Fiona. But I do have a number of questions, really. Let me just say I'm pleased that we've moved from 6 to 8 weeks down to more like, my experience at the moment is 2 to 3 weeks. But it still seems a long time, where other areas are getting same-day appointments or within the week. So I really want to know what plans are there to move to that figure rather than one that's 2 or 3 weeks, which I still think is far too long.
So I think some of this is we've seen a significant increase in demand for phlebotomy in recent years. So we've gone from 30,000 appointments per month into 2020 to 45,000 appointments currently. So that's obviously a significant increase. So one of our challenges is managing that additional demand, working very closely with primary care around the understanding of what is considered a genuine urgent appointment. So some patients require blood testing to be done same day or next day. Some of that's to do with cancer treatment and chemotherapy. Other patients is around that routine, and the expectation currently is routine appointments within around 3 weeks. So again, we are largely delivering on that with the additional changes that we've made. I think there's opportunities for us to consider how we maximise the availability of those slots and the transparency of where they are. So I think that's going to be the current thing to ensure that we're able to, patients can see really clearly where they can access those slots next.
Okay, I'm still not sure you answered my question in terms of reducing that time. I'll ask another question. I'll go to members. A lot of areas, GPs do an awful lot of blood testing. I know not all GPs have the facilities to do blood testing. And I'm often asking myself the question, why aren't more GPs doing blood testing? Because often you can get the same day appointment. So I guess my first part of the question is, why is that? And how much are GP practices paid for taking a blood test compared to the contract that you have with a number of private companies in terms of phlebotomy services?
So I'd need to come back to you about costing. That's not information I've got to hand today, but we can get that information, and obviously colleagues from Alex from the Integrated Care System can support with that, because a lot of this will be around local negotiation with practices as to the level of service they offer. I don't know if there's anything specific you'd add around the primary care side.
Sorry, I can come back with specific numbers, but my understanding is that the provision depends on whether there is a local enhanced service agreement in place, but the payment scheme is similar or equivalent to the one that the trust is paying through that service.
So I know GP are basically private practices almost, but so what's not making it attractive to them to want to take bloods within the communities where the GP practices actually are?
I think William Guy, my director, who I hoped would be here today, would be a better place to answer that. But I think it's a combination of both the financial viability of it, but also the staffing capacity that they've got. So sometimes it's the case of the choice. We cannot make all practices take up that service. We can, however, explore, and where we've got an indication that there is a need and request and willingness to deliver that, we can explore that further. So happy to bring more details to the next meeting.
Councillor Spate?
Yeah, at a previous meeting, and I can't remember if it was a member or a guest, spoke about the possibility of the Thurrock area, because of the problems that we've got with numbers and backlog, exploring the possibility of sort of community phlebotomy, whereby we train, the health trust or whoever trains a number of volunteers who could be located at community hubs and other centres. It's certainly something that has happened in other areas, and I believe that the message was, well, we'll go away and have a look at that and see if it's feasible. So I just wondered if there had been any efforts to look at how we could engage with people. If you remember, when we were in the depths of COVID, we harnessed the skills of a huge amount of community volunteers who were quickly trained in how to deliver vaccinations and other items of care. So it does seem something that we ought to at least keep a weather eye on and actively be looking at. So I wonder if any progress at all had been made, or any investigations had been made at utilising community volunteers to help with the phlebotomy backlog.
I think it's, again, if I may, if that's okay. I think William just joined in the perfect time, because we're just discussing the primary care phlebotomy, William, so you might want to take this one forward.
We have taken the strategy here that we wanted to explore firstly with the trust and make sure that we capitalise on the fact that there's been a re-procurement and further capacity being injected to the pathology services. But meanwhile, we're also looking at the additional roles that are within GP practices. So we currently got over 80 people employed through the R scheme, and there are opportunities to train some of those practitioners to deliver that. But Will, you might have more details about the plans that we discussed in last meeting around the possibility of training some volunteers and any other additional roles to potentially deliver phlebotomy locally. And again, there was a question around the pricing for phlebotomy in primary care, so we confirmed that it's a similar or equivalent as it would have been under the trust. Does that help?
So in terms of the pricing of the primary care phlebotomy service, we've done a bottom-up costing exercise with primary care across Mid and South Essex, and we pay £3 per blood, which I think is slightly higher than the rate we pay the hospital, but that's because they're not going to be doing it at the same scale as the hospital. And that arrangement is in place and can be provided by any GP practice in Mid and South Essex. At the moment, not many do in South West Essex. Historically, they haven't done. I think because of the wider pressures on primary care, it's not something they've indicated they wish to do at the moment. However, I think we can certainly have further conversations with primary care providers given the context of the current challenges.
Thank you. My table keeps moving. Councillor Fish.
Is there any part of that was an answer to my question? Because I didn't perceive there to be.
The answer is we've taken some steps to explore volunteers, but we started off with the R's roles. So, and again, as Will said, further work to progress.
So you've taken some steps. What are they? It's easy to come up with platitude. We've had a look. What is the proof of the pudding is in the eating? What have we actually done?
As we said, we've managed to map out the finances to be able to understand the costs that we are able to pay for these services. We've also looked at the capacity that we've got through the trust and through the primary care.
So we've not approached organisations like Health Watch, who have very good connections with our local community hubs and talked about possibilities. And we haven't spoken to the council that operates the hubs about the facilities that might be available to help ease this backlog. We haven't done anything in practical terms.
We have indeed. We've explored premises first, because in order to provide phlebotomy, we need specific amount of rooms. They have to have certain requirements in terms of the size, particularly when we talk about phlebotomy for children. So we've started exploration. We're on the journey.
Thank you. That's good news.
Councillor Fish.
Thanks, Chair. It's mentioned about the huge increase in demand for phlebotomy services. Did that come as a big surprise to people? Because you'd have thought that you could have anticipated that there would be that demand if the systems joined up, and therefore, something would have been put in place to cope with the demand.
Thank you for the question. I think demand is multifactorial in terms of why we're seeing that. Some of this is to do with population growth, and when Mid and South Essex Foundation Trust was set up, our catchment was 1.2 million. We're now already describing that as 1.3 million. So actually, we're seeing material change in our population. I think with the improvements in pathology and blood testing, there are now more procedures and tests that can be managed through the taking of blood. We know that patients who receive long-term medication now have an increasing requirement to have their bloods routinely monitored. So some of this is because of improvements and benefits in healthcare that we're seeing, that we need to do more blood testing to support those patients, and some of that is to do with demand around our population.
So surely that could have been anticipated, because if the system's joined up, then those improvements and those sort of ways of improving medical care, and more important, some blood testing, if people are aware that that's happening, why hasn't there been an increase in the number of people that are available, number of staff or the facilities available to carry out phlebotomy services?
So we're currently undertaking our business planning round for 2024-2025, and as part of that we are mapping out the current levels of demand so that we can anticipate the additional services that we're going to need going forward. You will be aware that the pathology contract that's currently with Pathology First is we're currently out to tender for a much larger single integrated pathology procurement, and as part of that we've got a duty also to ensure that we're right sizing the service for the future.
Councillor Tandy?
Yeah, if we're obviously looking for volunteers to do blood testing, what qualifications do they need? And what's the process?
So I don't think we're at the stage yet to go out for volunteers, because I think on the basis of what we've heard from my colleagues in primary care, we've got a number of roles already that have been invested in within practices. But obviously within a hospital it is typically a band 2 or band 3 qualification. So there's an element of training that an individual needs to undertake to be deemed competent to take blood. Obviously if we take blood inappropriately, not only can it cause harm to the patient, but it can damage the sample, requiring a further sample to be taken. So there are some very clear requirements around, the clinical processes needed to take blood from a patient.
So roughly how long does the process take?
Not sure on the current trading requirements, but I think is it a 6-week course?
I haven't worked in pathology in a little while, but my understanding is the training course is 6 weeks, and then there is a supervisory period where phlebotomists have to be supervised during the bleeding for up to 3 months, depending on how quickly they develop the skills, because it is definitely a specific skill set to do it well.
Okay, thank you, James. Fiona, I mean, I really want to keep this on the agenda. I have to say every political party in Thurrock is concerned about the period of time it has actually taken to get blood tests, particularly during October-November period. Glad to see there is an improvement, but there's still some way to go. So I hope that maybe you'll follow up some of the recommendations made by the councillors today to look at some other options. Can I just ask, in terms of the procurement process, will you be looking at, as part of that, the option for volunteers to be part of that process and how they could be supported if we did go down some of the volunteer routes?
I mean, it's very much a live discussion around what the specification needs to look like, and we're currently in the dialogue phase with the two bidders that we're working with. So it's certainly something we could consider. It would need to be very carefully managed around sort of governance and patient safety, but if that's something that we think is worth exploring, then we can certainly look at that.
Okay, thank you.
Thank you, Chair. I'll ensure that there is a access times update for phlebotomy included in the report going forward for our Thurrock population. Thank you. So if you're happy, Chair, Nikki's joined us, so we can move to Nikki Abbott, who's here to talk to us about the CQC update for maternity.
Just before that, I just want to be clear that we are working towards, what do you think the standard time frame should be? And from my point of view, we should be waiting any longer than a week for a blood test in Thurrock. That is my view.
So there is, to be fair, no national recommendation about what we have KPIs for many things in healthcare, as you know, but we do not have a KPI for what urgent blood testing time is. So we're working towards 3 weeks as our guide. Again, there are, as we've already said, there are availability appointments sooner than 3 weeks, but it's very much dependent on clinic capacity and location.
If I may come back on that, Chair. So there is a availability for the GPs to request an urgent next day bloods. They've got specific dedicated phone number that they can use. So if there is a clinical need for it, that is available for patients in Thurrock.
Okay, so we'll monitor this with interest. Okay, so maybe we can come back with an update in March's HOS meeting, please. Okay, so I'm picking the agenda. Was there other things you want to talk about, Fiona, before I actually go on to some of the issues I want to talk about?
No, I was only concerned, Chair, with addressing the issues that we were requested to update in relation to the estate's capital backlog and maternity, but we can do that in whichever order pleases yourself, obviously.
Right. So I'm keen to look at that now, the estate backlog, because it really made some quite grim reading. Talking hundreds of millions of pounds by the looks of this. So I'd like to ask, why have we got this maintenance backlog? I think that's the first question to ask.
I think you can go back decades of partly underinvestment and managing the sort of difficulties of applying the underinvestment. Where we are at the moment, we've had the survey done in 2021-22 to understand what the detail is, where previously we didn't have it centralised. Now we know where we stand. We can sort of start understanding the reasons it happened and how we can recover from it. And I think there are two reasons of why it happened. One, as I mentioned, was the lack of funding or capital availability. And it's not something that MSE are alone in. There's a large number of acute trusts across the country who are suffering from the same position. Even with availability of capital, such as coming up in the next couple of years, the challenge is applying it in a very busy acute hospital, because it requires so much, disruption and relocation, decanting of entire material parts of services in order to free up the space to actually deconstruct and reconstruct the space and then move back. And of course our priority is about clinical care, so that challenge is the one that we struggle with at the moment, but at least we know about it. We're taking some steps internally to increase the agenda of estates within the trust. For a start, we've employed myself, which was a role that previously wasn't in post, and I'm putting together an estate strategy that is going to address the capital plan going forward. We're successful in acquiring some capital towards £118 million acute reconfiguration, and whilst that's not particularly addressing capital, the byproduct will be that we can address that at the same time as doing these new builds and refurbishments.
Okay, so I guess my main concerns at the moment is Alston and Basham Hospital, which is the hospital most people in Thurrock actually use. So, what is the plan to get those buildings up to a good standard?
Firstly, it's to accelerate any backlog that we can with available capital. And this year, for example, we've spent about £5 million that was planned on backlog, but we've also had some slippage on other capital schemes, and we'll be able to redirect and accelerate spend in some specific areas. But because of the availability of time and capital, we're doing it in areas that minimise disruption to the clinical services. I've mentioned the acute reconfiguration capital, which will help us, but there's going to be no substitute for actually applying for and acquiring more capital and the airspace and thought space to apply it. So it's going to be a long plan. Even if we had £20 million for 5 years, I think the agenda is quite a challenging one.
I agree, it's very challenging. Okay, we've had reports about Basham Hospital having leaks in its roof, and we've got our local hospital also that seems to be run down, and that's very, very visible as you walk round. So are you applying for more funding from government to deal with these issues?
Always, and at every opportunity.
So I guess I'm trying to work out, is it a government funding issue or is it a bad management issue in terms of local trusts managing their estates?
A bit of everything, I think. I haven't been around in the trust for a long time, but I know from looking into the backlog and the condition that you don't get into this position overnight. It's a decades-long sort of slow burn. The mitigation is around prioritising the clinical services, which are obviously the priority to keep going. But perhaps where you're talking about the sort of lack of attention, I would say maybe there has been some around that where estates hasn't been sitting at the top table. That's something that we're addressing in MSC, and we're putting estates higher up the agenda so that it fights for the airspace and available capital and the strategy going forward, so that we can work with our clinical colleagues to engineer the refurbs into the programme.
Okay, Councillor Spate.
Being slightly more forthright than the chair, who is more diplomatic, again, we sort of get a very bland statement there of we're applying all the time, and a lack of detail. Can you tell me what the Trust has applied for in the last 5 years, whether it's been successful, if it hasn't been successful, why it hasn't been successful, and what it's done? Because I served on the board of the governors at the hospital 10 years ago, and I was hearing this same story. And all I've seen in the 20 years that I've been in Thurrock and been watching the Basildon Hospital in particular is ream after ream after ream of senior management drafted in and expensive managers and more people coming in. And, you know, the poor old health service is down at the bottom of the queue. And you know, you're all paid an awful lot of money to do what you do, and you should have this detail to your fingertips. You should know what amount of money you've asked for in the last 5 years and what's been refused and why it's been refused, because then it's our job as politicians to come in and harangue the government. But if you don't tell us, we're never going to be able to help you.
I'll take the point going forward to tell you so that you can help us. Specifically, I don't know the last, say, 5 years of applicants because I haven't been around, and I can always give you that. So I'll go back and check that. Be interesting for myself. Capital applications are always massively oversubscribed, and so each year we apply to the department for as much capital as we need, and we spend what we get. I can't give you exact numbers because I haven't been around and didn't do the actual submissions.
Okay, well, I won't labour the point, but you know, I will. You know, we have, and we're going to talk about it later on. You know, we have people come and standing in Thurrock, senior politicians holding lead roles in government. Our friend Jeremy being one of them, who come and say an awful lot of things, and you're knocking on their door at the government and saying we want this, that, and the other. And as I say, I think, you know, you've got to start to become more political yourselves. I really do think, you know, maybe, and this is a gut feeling, you know, you've got the eye on the next job up the chain, so you don't want to upset anybody, you know. And I've looked at the way people have progressed from being a general manager at Basildon Hospital and now being virtually in charge of everything, and actually has achieved, as far as Joe Public's concerned, very, very little. So I don't want to hear and see about personal development plans for senior managers. I want to see action where we, as elected politicians, can go and put pressure and get results, because we've got this backlog that we blasely talk about because of inaction, because of a lack of protest, because we've accepted it. And the time has come when we're not accepting it, and I'm damn sure that we're not going to carry on accepting it in Thurrock anymore, because we're getting the bum's rush every time, and it's got to come to an end. And I don't care whether you're red, blue, whatever colour I'm supposed to be, we are going to unite now and start to fight, because we're sick of being treated like second-class citizens.
Fiona. Yeah.
Thank you, Chair. I just wanted to come in to say that the situation that we are in regards to our mismatch between our capital requirement and our capital availability is very visible at board level and is one of the highest risks on our BAF, and is escalated regularly through to both region and the national team. We are required to report annually on this information. So, and as Jamie referenced, we're certainly not actually even in a relatively poor position compared to a lot of hospitals in our country. So that's just to give us the wider context. In terms of proportionality of what we get to what we need, I think in the last year we had about a third of the available capital for what we needed to address our highest risks in terms of backlog maintenance. So that's the relative proportionality. And I think, Councillor Spate, you're right. We need to work better together in order to ensure there's greater understanding and greater collaborative working to get what is needed for the residents.
Thank you, Fiona. Councillor Fish.
Thanks, Chair. I note from the report that in the table where you're talking about what repairs are going to be done in which hospitals, which facilities, Allsit, it says that the repair that's going to be done is critical repairs. So can I take it from that then that the strategy for Allsit is to wait until a piece of the equipment or piece of the building is falling to pieces before they're going to do anything about it?
It's more to do with the availability of capital than when it falls to pieces. That doesn't sound like a satisfactory answer because it may whoever comes first, really. So there is mitigation in place with our EFM staff who obviously do the reactionary maintenance to try and prevent the sort of the incidents from happening and the physical falling to pieces. But there is a programme of sort of minor works to keep it in working order whilst we await proper capital spend.
I guess my worry around Dorset is it gets in such a poor state of disrepair. You close the hospital on the poor state of disrepair, rather than the fact it's something that's actually really important to the people of Thurrock. So can you assure us that the building will not get in such a state that that would happen?
I think I can say we won't let it get into the state of repair that it needs closing as a result of the condition. Our priority is to keep it open and the clinical services running.
Okay, thank you.
I mean, just coming in on that, you know, you look at the backlog overall risk summary, risk category high, you know, and you look at Basel and you look at Broomfield, you look at Southend, you look at, well, St Peter's is not great either. In fact, it's slightly more. And yet, you know, also it's £4 million that's high risk. So I suspect, you know, I'm sorry, I don't think we are being preventative. I genuinely share Councillor Fisher's concern that we are sitting back and waiting until it falls apart and then it don't get fixed. Because the figures tell you that. When you look at the figures, given the size of Basel Hospital and given the size of Allsit Hospital, that's incredibly disproportionate. One's 3.3, one's 4.1. Doesn't seem to make any sense to me.
I suspect that's part of the historical underinvestment and with a strategic relocation of services, because whenever we look at the future of a hospital, the natural instinct is to not invest. So I think that that has exacerbated the backlog at Allsit.
Okay, so again, I really think we need to keep this on the agenda. There's real concerns about the state of the buildings, our sick people are attending. So I do want to keep this on the agenda, and I do want us to work closer together in supporting bids for funding. And we can try and apply as much political pressure as possible to try and make sure the Trust gets the money for the hospitals we need. Okay, is there anything else in the reports regarding the Trust that anyone wants to look at?
Nikki's there to do.
Oh, Nikki, sorry, my apologies, Nikki. Okay. Right, okay, over to you, Nikki, thank you.
Thanks, Chair. So I'm here to provide some updates on the progress that we've made against the CQC inspection that happened in June 2022 and the report that came in December 2022. You'll see that we had a total of 38 actions from the CQC, some must-dos, some should-dos. 20 of those are fully complete and fully evidenced and therefore signed off as complete. We have a very rigorous process at MSE of evidence required to sign off an action as complete, with 3 months' worth of audit to prove that an action has been embedded in business as usual. So 20 fully signed off, 5 complete going through the sign-off process, and 13 remaining still in progress. There are weekly meetings happening, trying to ensure that we close off the last of those in progress actions, and we have sustained and embedded those that are green so that we can provide the evidence. There are some areas still not quite achieving, so still some work ongoing, particularly around staff appraisals. You'll see in there there's been some good news around things like recruitment, etc., and mandatory training achieving the targets we need it to. We've also recently been able to sign off our CNST requirements. So for maternity, you have 10 essential actions you have to sign off, and we're in the process of signing off that we're compliant with all of those and their safety actions. So lots of good news, but still a bit more work to do, and our current intention is to have all of that completed by the end of the financial year.
Okay, do you know roughly when you may be inspected again?
So we have a Section 31 on our licence at the moment. We're at a point where we think we can apply to have that removed, and we fully expect that that will trigger a further CQC inspection. Obviously, we could get an unannounced inspection at any point in time.
So positive news, moving in the right direction. It's good to hear. Any questions? No?
It's not a question, but as I usually dish out the brickbats, in fairness, that is a good progress report. So, you know, in fairness, I acknowledge the work that is being done. It's always a concern, maternity. It has been for a long time, but it's really pleasing to see that you've got some productive action. So well done to your team.
Yes, Kim.
Thank you. Really, it's just to say that as Health Watch, we just started a piece of work around getting people's lived experience of using the maternity services. So we've had it open now for 3 weeks. We've done a lot with parents' panels, children's centres, events. We're running it till mid-February, but we've already got over 40 responses and feedback and experiences. So at the moment, the biggest thing that's coming out is the lack of consistency with midwives during their period. But that at the moment is the biggest thing that's coming back. But once we've finished the work in February and we do the report, we'll share it, obviously. So you've got like people's lived experience of their thoughts around it. And we're also speaking to the dads. So.
Yeah, thank you. I think that'd be really interesting. We do already work really closely with our Maternity and Neonatal Voices partnership to get user input, but very happy to get further evidence.
Any other questions?
Yeah, are we to the end of the scheduled items? Because in terms of the trust, because I'll just say to Fiona, Ronald Ashdown.
So, Councillor, as I've expressed before, we won't cover the details of any individual case at this committee. It's not appropriate. However, I can confirm that the action plan and all the associated documents have been shared with the Thurrock Safeguarding Committee, and I have got some detail around the lessons learned that have been undertaken and shared widely across the Trust in relation to safeguarding incidents and in response to coroner's report in relation to recent cases. But I think it's really important that we don't discuss individuals in this forum. So there has been a lot of activity within the hospital to ensure that lessons have been learned. There's been a programme of training and audit on the wards around nutrition, hydration, mouth care, etc., and all of that work is still ongoing, and the evidence to support that is submitted alongside the action plan to the Safeguarding Committee at the Council.
Thank you. That's pleasing to hear. What is incredibly disappointing is that I had to raise it. I didn't raise it on the minutes because I wanted to, because I'm a horrible person and I wanted to mention it now. You made a statement 2 meetings ago that you would bring a report to the next meeting. You forgot to do it. You then made a statement saying you'd bring a report to this meeting, and clearly it's not that important. It's only a bloke who died. Don't worry about it. And that's being facetious and silly, but that's the way I feel. And I spoke about the management responsibility within our care services. I know that the directors and staff within Thurrock Council that I work closely with on health matters, and there are a few of them, we work as a partnership. We share, we trust, we speak, we communicate. I just find it incredibly insulting that you made a promise to turn up at this meeting with a report, and if I hadn't raised it, you wouldn't have done it. And I just think that sums up why the NHS management is in the state it is. I think it's dreadful, and I'm sorry to be personal, Fiona, but you said you would do it. And you could have brought that information that you've just given us in as a form of report. You didn't have to name the guy or whatever. But this is a gentleman that the health service and your hospital let down badly. And not to mention him when you said you will or bring a report in is a disgrace. I'm sorry.
So with respect to Councillor Spate, the information has been shared with the committee chair and we have responded to you offline. I re-emphasise that specific case details are not appropriate for this committee, and that I have confirmed through appropriate channels the actions that have been taken. So apologies if my intention to respond when the matter was initially raised has not addressed your concerns in this committee, but it has been addressed where I felt appropriate.
I'm not going to go on anymore, except to say this is a matter that was raised not by a councillor, not by a Health Watch organisation. It was raised by the county coroner, who asked a lot of questions. This was put in the public domain by the Essex coroner, who damned your organisation publicly and gave you an opportunity to respond. And this meeting gives you, as the health service, the platform to... Don't have to do the names. You could have brought forward the information that you gave us. That's sufficient. Okay. But, not to share it is just wrong.
Councillor, I do think... Okay. I do think Fiona's tried to answer the question today. Yes, I think I agree that it would have been nice to have a report, lessons learnt, being brought here for discussion. But I think fundamentally what I'm really keen to find out is we don't make the same mistakes again, and that that appropriate actions have been taken, apologies have been made to the family, and this doesn't happen again.
I can confirm that the appropriate steps have been taken with the family, and that has been reported through to both the coroner and the Safeguarding Committee.
Thank you. Can I just ask a question about cancer care, please? Because the Trust target is 75%. People are seen within 28 days. That's currently operating, I think, in October around about 60, just over 60%. I'm really keen to find out what actions have actually taken to improve that and where we are today.
Thank you, Chair. So, as we previously discussed, we are managing our services in line with the national expectation that we meet the 28-day faster diagnosis standard in 75% of pathways by the end of March. Performance as per the report, and we have been seeing a continued improving trend on this. However, we have also seen impacts in relation to industrial action. So to date, in this year, a total of 746 inpatient surgeries have been cancelled, of which 55 were cancer. Obviously, in the periods of industrial action, we take every possible step to prioritise cancer patients, and we will not cancel a cancer procedure or appointment wherever possible, but we have to prioritise our available medical workforce to ensure that our emergency department and wards are safe, and it's not always possible to avoid any cancellations. A total of 3,800 or thereabouts day case procedures were cancelled. About 420 of those were cancer, and in total almost 34,000 outpatient appointments have been cancelled. 9,000 of those were in relation to cancer patients. So just to describe that, that is the underpinning problem that we're seeing, and we have got greater mitigation in place planned through January and February to return us to the positive trajectory that we've been seeing in relation to delivery of the faster diagnosis standard. At this point, we don't have planning guidance as to the next steps around that, but so approximately 10% of our impacted activity through the industrial action periods has directly affected cancer patients.
Okay, that's not good news, is it, really? Okay, well, as soon as they resolve the industrial issue, the better. Any other questions before we move on to the next agenda item?
Can I, Chair?
Councillor Polly.
Thank you, Chair, and apologies for my lateness to everybody. Fiona, obviously I'm appointed on the Council of Governors by this authority, and we've got an extraordinary meeting next Tuesday to do with the community beds. Is this to do with the capacity at St Peter's Hospital at Malden and providing extra bed capacity at Brentwood? I'm not quite clear why it has to be an extraordinary meeting and why. With our Woolsett situation, the fact that this has been dragging its heels for 8-9 years, and the situation has arisen at St Peter's in Malden within the last 6 months, and now we've got an extraordinary meeting about it. I'm just trying to apply some logic to how Malden get this response and get action this quickly, and Thurrock seem not to be able to get the same priority. Thank you.
So we do have a scheduled extraordinary public board meeting coming up, which I believe is what you're referencing, Councillor Polly. It will look at our options for the delivery of intermediate care and stroke rehab beds across the entire of MSC FT, so including the sites that you reference. So it won't cover anything else. It is literally about the intermediate beds provision, including the intermediate beds here in Thurrock.
Correct. That is my concern, that we're looking at Brentwood Community Hospital as a possible site for additional community bed space to accommodate Malden's situation, and that is an overflow service for Basildon Acute and obviously Long Lane, our Thurrock Community Hospital. You know, the thought of our stroke patients having to go out to Braintree or you know, further afield, when I just yet again, sorry to be Well, no, I'm not apologising. I'm not going to apologise for banging Thurrock's drum. I mean, initially it may look like it's a service that is related to another trust and not immediately to us, but I do feel that there will be a domino effect for Thurrock.
If I may come in, Chair, I think the conversation that you'll be having next week is about looking at appropriate options and capacity. It's not just about additional beds, it's just about appropriateness of the beds in appropriate locations versus the capacity that we've got, and that is also a knock-on effect of the premises available to us. So we want to make sure that we're serving our population in premises that are safe, and that is the main driver of this discussion. And no decisions have been made yet. It's your first engagement conversation, is my understanding. So as soon as we're able to provide any more details, we'll bring this to this forum as well. But I think point well made. However, clinically speaking, we've got a lot of buying around looking at the stroke pathways in particular. So I would encourage considering, even if that means travelling a little bit further, to get better, more rounded up services for our patients. Again, we will be engaging if any proposals are being made.
Okay, if it's okay, I'd like to move on. I've got a presentation, e-put, an update and a PowerPoint presentation. So I can ask Paul Scott to present his item.
Thank you, Chair. Hello, everybody. I'm Paul Scott. I'm the Chief Executive of Essex Partnership Trust. I'm joined by Alex Green, who's Deputy Chief Exec and Chief Operating Officer, and Rita, Partnership Director for Thurrock. So we'll share the presentation, if that's okay, Chair. I was last here about a year ago, and we gave a bit of background to e-put. But there's some new faces around the table, so forgive me if I repeat it if you were here last time. I'm just going to make sure everyone understands what e-put does and where we cover. I'll talk a little bit about some of the work we've done to make things better in e-put. Alex will talk about some of the more operational side of things where we're making some real improvements, and Rita will bring the Thurrock focus about the work we do. And then we'll open to questions, Chair, if that's okay. We'll try and be brief, so we've got more time for questions. So e-put is a large and complex organisation providing mental health and community services across Essex and beyond. We have been working very hard since I joined in 2020 to continually improve safety. When I joined, I had to face a health and safety executive prosecution about failure to manage ligature risk in our inpatient mental health wards, which highlighted some considerable concerns, I think, about the state of the environment in those wards. And we identified that there's quite a big journey to go on to get to the levels of safety that we want to see in all of our services across Essex and beyond. So we've been focused on a safety first, safety always strategy. The figures in here will be updated at the end of this financial year. They'll be bigger at the end of this financial year, but in the last 2 years we've invested £20 million in our inpatient wards, and we're now very comfortable, very sure that they're in a much better place and meet the requirements of a ligature safe environment. But that's an ongoing piece of work, and we'll continue to maintain the wards in that extent. Most of our activity and the support we give to the population is in our community mental health services, and we continue to invest in those as well, so they're continuing to grow. And at the date of this report, we've invested over £20 million across the whole of Essex, but proportionately so in Thurrock as well. And that includes connecting more mental health practitioners with primary care, which, as ever, when you bring a new service in, hasn't always gone smoothly, but I think overall is going down very well with both patients and primary care, and Alex can talk a bit more about that. We've really invested in some cutting-edge technology to support clinicians when they're looking after our patients in their wards. So we've got Oxy Health in there, which is a new technology and proving to be very helpful in improving safety. And we have made further steps towards digital improvements, and part of our safety concerns is the number of electronic patient records we have to operate across our services, which number 7. I'm really pleased that we've managed to, in partnership with MSEFT and MSC ICB, we've managed to secure investment for a new electronic patient record for both mental health and acute services, which I think will really enhance safety and effectiveness of the way we deliver healthcare across Essex, Thurrock and Southend. We've also worked really hard. When I joined and during the peak of COVID, we had significant, really significant challenges around staffing. We had 40% vacancies on some of our wards for qualified nurses, and that proved to be a very, very challenging environment both for patients and staff. We've worked really hard to target recruitment, work with our university and make sure we retain students in the system. And we have recruited from overseas as well. So we're now really pleased to say that our staffing level for nursing has gone from 40% vacancy to just over 10% vacancy today, and we plan to have that to 0% vacancy by the end of the year. We've invested in clinical leadership. When I joined, it was quite a centralised organisation that controlled things from the centre. That meant people who were running services and best placed to make decisions were disempowered and felt excluded from decision making. So we've really invested in clinical leadership, and I think Rita will be a really great advocate and able to describe how that's looking locally as well. And one of the things I heard when I spoke to patients and families who had suffered harm from our services or lost people in our services was the disconnect between what they were saying and how they felt heard and listened to, and how they felt they could have influenced outcomes if they were listened to. So we've really invested hugely, actually. I'm really proud of this, of around over 200 people who are either lived experience ambassadors, patients, peer support workers or family members to be part of our decision making, be part of the ward team, or advisors in some more of service development work as well. I really want to continue to expand that. It's been a great success. It challenges our culture and makes us think differently about how we support our population. So that's something, again, I'm really proud of. I get the sense that you won't want me to dwell on strategy, but strategy has been important to us in a way because it's allowed us to bring together a wide range of stakeholders and community members to try and work out what direction EPUT needs to go in. And we've been really pleased to involve our staff, our patients, and a wide range of stakeholders across Essex, Thurrock and Southend to set out our priorities and the direction of travel for the care we want to give. And the headline for that really is to really make sure the community offering is as best as it can be to keep people out of hospital and to make sure we're delivering care in a trauma-informed way, which moves us away from a sort of medically driven care, really. And why that matters is because we can make commitments on the back of that conversation, and we will be publishing on our board every I think it's 3 times a year. We'll be bringing to our board an update on delivery and the actions we've taken as a result of that strategy and the progress we're making. So, and that will be in public, so we can be held to account in public on that. So I think you know, and always balance everything we say, actually, because we've done lots of things and we're proud of what we've done, but we do so with huge humility because there's an awful lot more to do to get to the level we want. We've got a really high ambition for EPUT, and people around us told us they want us to be the leading mental health and community provider in the country, and we're working towards that, but we're not there yet. And we'll continue to learn, implement and change to get to the place we're going to do that. We're doing that in the context of a statutory inquiry into death and mental health in Essex from 2000 to 2023, which we are expecting the terms of reference to be published imminently. I haven't seen them yet. I've seen the draft like everybody has. And we'll make sure that we're very open to the inquiry. We'll provide all the information we can, and we help them give the families the answers they deserve. We'll do our very best to do that, and I'll come back to that later on in the presentation. There's also, as a consequence of COVID, there's, just to make members aware, there is quite a backlog in coroner's inquest as well, and we're seeing a bunching of historical cases coming through in the next few months. So there'll be difficult stories, I think, coming from those, and some of those in the past, some of them are more recent. But we're very clear that we'll have a proper oversight of any findings that are new to us from those inquests, and make sure we implement change as quickly as possible as a result of that. But I just want to make the committee aware of that. I'll stop there, Chair, and I'll ask Alex to just take us through some of the areas around safety and the CQC, and then hand over to Rita to talk about Thurrock.
Thank you, and good evening, everybody. I'm going to talk a bit about our approach to safety. That word strategy is in there as well, and then focus a bit on our CQC inspection, the actions that we've taken and the way in which we're approaching those to ensure that we've got sustainable change. I know colleagues were interested in the way that we manage ligature, so I will talk a bit about the management of ligature risks on our wards, and then highlight a couple of innovations that I hope are making a difference to the people of Mid and South Essex, including the residents of Thurrock. And then I'll hand over to Rita for that very local approach. So I think when we spoke to you last, we were midway through our Safety First, Safety Always strategy. We're in the final year of that, and the focus of that final year has really been an improved way of tracking the benefits of the safety strategy realised through new ways of working. Part of that has included our patient safety incident response framework. We were an early implementer of that framework. It focuses very much on working with people who've experienced harm, or their families or loved ones, trying to get them the answers that they want, but very much focused on learning lessons as well, and we are supporting other trusts to roll that out at the moment. A real focus on getting the basics right, as well as taking innovation forward and upholding high professional standards. And I think, importantly, evidencing the feedback loop from patients, families and partners in our improvement work. Paul mentioned talking to people who'd experienced harm or had concerns about their care and their loved ones, and we meet with them on a regular basis. We try and intervene early, but their experiences are really important to what we're doing. Excuse me. As we come to the end of the Safety First, Safety Always strategy, we will move into our new quality of care framework. That was signed off by our board in December of last year, in 2023. It will focus on three key themes, which are that continued focus on safety, on quality and the effectiveness of our services. And I think it's really important to say that this has been co-created with our staff and with people who use our services and their families. And it's a combination really of what's meaningful and important to them, as well as regulatory frameworks and the kind of must-dos as well. So 40% of our services were inspected in our most recent CQC inspection. I think when we visited last time, 2 of our wards had been inspected following the dispatches programme, unannounced inspection, and then our well-led inspection. I think it's needless to say we were disappointed by the outcome of that inspection and the shift in our rating overall to requires improvement. But we have responded rapidly to the concerns that were raised, and we are concentrating on closing the actions down, but making sure they are sustained as well. There's a great deal to do, and we're concentrating on making lasting improvements. But the CQC did recognise some good practice as well, and I think it's important to raise that as well. Patients and relatives described care as safe and compassionate. Patients said they felt valued and respected. And our inspectors acknowledged we were taking steps to addressing learning in the organisation, really making that very systemic and embedding lessons learned. They highlighted the mental health urgent care department over at Basildon, which I'll talk a little bit about later. The ambulance car with a joint mental health practitioner. The first neuromodulation service in the east of England. And if we think of electroconvulsive therapy, that's a less invasive form of therapy. One of our people with lived experience has been very key, I think, to highlighting the brilliance of that service and talking about the difference that it's made in his life. Expanding our Operation Courage service, which is a service for veterans and for their families as well. The work we're undertaking with both the East of England Collaborative, which is specialist mental health services, and our community collaborative with partners from NELFT and Provide as well. And just to highlight, our rating for our substance misuse services rose from requires improvement to good. So we have taken a new approach to responding to the CQC concerns, because an action plan just doesn't cut it. And we wanted to involve very much the people on the ground in developing those actions so that they could be completed and they could be sustained. And our approach looks far more deeply at the root causes of things that have gone wrong. We've, as I say, we've involved our colleagues on our wards and in our community services in developing that action plan. We meet with those colleagues on a weekly basis to update on progress of those actions and close them down. And what our staff are telling us is they feel far more confident in that process. They are confident they are going to be able to sustain the changes because they are meaningful and they feel they can make them as well. They feel their voices are being heard and they feel that the actions are realistic as well. I think the really important thing is that ownership of those actions are taken at a very local level, but with the right executive oversight. So we have a monthly report come back to our executive team. It's overseen by our board as well and by our system partners through a rapid quality review process, and then an ongoing dialogue which is led by our chief nurses across Essex. The CQC identified 73 must-do actions. We subdivided those into 275 sub-actions, and a third of those are currently closed down. And I think we've had some positive feedback from the CQC on our progress. So some of the key priorities that we've been working on as part of that action plan, we spoke about sleeping on duty the last time we were here. You know, we look after people at their most vulnerable on our wards. We have some very high acuity on our wards as well, and people who require some pretty constant levels of observation. And of course, staff falling asleep causes us great concern. We have made that absolutely clear as an executive team and a board that that behaviour is unacceptable. And we've reviewed our disciplinary processes. They are robust. I think we're confident in them. But as well as looking at individual failure there, we've looked at some of the more systemic issues, and we've concentrated on addressing those as well and ensuring that people are fit for duty when they turn up and they sign to say they are fit for duty as well. And part of our prevention of sleeping on duty has been introducing site coordinators, clinical site coordinators, who work across our sites on a 24/7 basis. So we've got leadership on our wards 24/7, 7 days a week. We've reduced our vacancies, as Paul said. A large concentration of those were qualified nursing vacancies. We did have an issue with temporary staffing, particularly agency staffing, and we've worked hard to reduce that. 220 overseas nurses, and I think we're seeing the real benefit of introducing registered general nurses onto our wards, concentrating on physical healthcare as well as mental health care, and some AHPs who have joined us from abroad as well. And we've got a comprehensive package of support for them, because it's really important we support them in our journey with us. And our support package received an NHS Pastoral Quality Care Award as well. So we're proud of that. Those staff are really embedding in our services at the moment. Our turnover rate has reduced to pre-pandemic levels. We're proud of that, but we're keeping our foot on the pedal as well. We are investing in a new electronic patient record. We're doing that hand in hand with our partners at MSc FT. That will bring the two organisations closer together, and it will help us to have an overview of our most vulnerable that is shared. So that's very, very positive news, I think. And I think we touched last time we were here on our Time to Care programme, which is a programme of innovation on our inpatient wards. It was signed off by our board mid-last year. We are talking to our ICB colleagues about funding that programme at the moment, but essentially it is about releasing our clinical staff from administrative burdens and giving them more patient-facing time and more time with families as well, to ensure that patients and their families are really, really involved in their care planning. We've also looked at our processes on our wards and tried to streamline those as part of reducing that administrative burden. And we've looked at how we use technology on our wards. I think when we were here last time we spoke a little bit about OxyHealth, which is a remote patient monitoring tool. We've introduced e-observations, which gives us an assurance that observations are being taken in real time, and there's a real-time recording of that as well. And we are digitalising our standard operating procedures, which makes it easier for staff because they're available on a digital platform. We've reviewed our standard operating procedures, we've simplified them so they are easier for staff to access, and it means that we have, as a leadership team, oversight of access to those standard operating procedures as well. So I said I'd speak a little bit about ligature risk, which is a method of self-harm that people use on our wards, and sometimes, as we know, that's had catastrophic consequences as well. It was raised in our dialogue with the HSE that Paul referred to earlier, and we have undertaken a programme of comprehensive work. So that £20 million of investment on our wards has gone into things like the provision of door-top alarms consistently across our estate. So we just have one area outstanding at the moment, and work is currently in progress to address that. And I'm really pleased to say that we have significantly reduced fixed ligature incidents on our wards. In the Thurrock sites, over on our Thurrock wards, we have had no fixed ligature incidents between January 23 and November 23, so that's our latest data. So real significant improvement there. But the work doesn't stop, because our risk has shifted away from environmental factors to self-harming mechanisms, so self-strangulation. And we're working hard on managing that risk, on really focusing on the clinical management of ligature risk and how we de-escalate people who are at risk of ligature. But a great deal of work to do, and we will sustain our concentration on that area of work. Our ambition is to have no fixed ligature incidents on our wards. We've got 370 acute adult and older adult wards across our sites. That includes our wards at Thurrock, but also Basildon and Rochford. And I do appreciate that Thurrock residents may be cared for in those wards at times of pressures in beds as well. And I've spoken a little bit about our Time to Care programme. We're really trying to focus on making sure admissions to our wards are purposeful, so we only admit when people really do require that intensive 24-hour care from our wards, and looking far more to community-based interventions and prevention. Just to highlight a couple of those, I referred to our mental health urgent care department at Basildon. So Basildon was chosen because the site was adaptable there and we could do it with some ease. It's had some significant investment. We've seen to date around 1,500 people through that mental health urgent care department. It is a far more appropriate environment for people who are experiencing a mental health crisis, and the majority of those people leave within 5 hours. The real focus is them leaving with a plan of care and support and transferring them back safely to community services. And I just want to give colleagues the assurance that that does not detract from the work that we're doing in Thurrock. So we're not trying to pull work through there, but it is an alternative and a safer alternative for people. We've also worked hard on our mental health suite at Basildon Hospital, and we're taking the learning from the urgent care department into our sites at Broomfield and Southend as well. And the mental health ambulance response car as well, so that was launched in Mid and South Essex in April of this year. It operates between the hours of 1 p.m. to 1 a.m. across 7 days a week, and essentially that's a paramedic and a mental health practitioner working together to go out, see people in their own homes when they're experiencing mental health crisis. And so far of the 636 people that have been seen, 84% of those people have been enabled to remain in their own home environment, supported by an appropriate care plan. So I think that joint working between us and the ambulance service has lots of benefits. There's learning from that as well. We've got a member of staff in the control room as well, helping to respond to calls, and we're hopeful for funding for an additional car in the Mid and South Essex area as well. So I will stop there. Just before Rita picks up, I just want to say Rita, I think, represents our really valued relationship with Thurrock, with the local authority. She is a joint appointment across EPUT, across NELFT and across the local authority. We're really proud of the work that Rita is driving locally to improve services for the people of Thurrock, but to bring a far more integrated approach to care and support as well. Rita, I'll hand over to you. Thank you.
Thank you. So I was going to describe my role a little bit more, just to give colleagues context. So I am a partnership director. I am one of 4 partnership directors across Mid and South Essex, but the only appointment which is led by local authority in conjunction with EPUT and with NELFT, which is our community provider. So I manage the majority of health and care teams across our Thurrock locality, and my focus is Thurrock, and delivering on our Better Care Together strategy, which really focuses, as colleagues are aware, on early intervention, prevention and integration, and working with residents within the community using the human learning systems approach, which is around actually working with individuals and finding the best solutions, working alongside them and not doing to them, but really working with the communities first and foremost rather than going to statutory services. But the focus of the discussion today is really to provide you in a... Oh, sorry. Can you hear me? Okay, otherwise I could get louder. I am a speech therapist by background, so any level I can hit. That's fine. Okay. So But for the purposes of today's update, really I wanted to focus first and foremost on patient safety and really talk about our workforce and how we support that safety element, and also how far we've progressed on the integration agenda. So first and foremost, from a workforce perspective, Paul and Alex have given you an overview of where we are in the improvement position. And within Thurrock locality specifically, so across Mid and South Essex, we're sitting at around 10%, and actually we're just below that in Thurrock. There are 3 key areas in terms of recruitment that we are focusing on. Further establishing our relationships with the universities. Also offering appointments to individuals that have completed their placements with us. We are also very lucky and privileged to have international nurses within our localities and working really hard to integrate them within our teams as well. But the biggest highlight and strength this year is to the launch of a joint integrated recruitment campaign, which is across local authority, NELFT community provider and EPUT. And this is based all around our Better Care Together strategy, and we will be looking at having a joint recruitment days, having a website which will have talking heads, so videos about our Better Care Together strategy and the strength of and the difference of working in Thurrock, which is all around working with individuals. This also allows us to talk about the different career pathways for individuals that want to come and work in Thurrock and grow in Thurrock with us across healthcare and housing. So real opportunities to bring people to us in Thurrock through using our Better Care Together strategy and how far we've come in terms of that integration agenda. In addition to that, in terms of focusing on our key services and support, supporting our communities, just getting back a step, I thought it would be helpful for members and colleagues to see our position in terms of sickness appraisal supervision locally. So our sickness levels across Thurrock are below target. They're sitting at 2.4%, which is quite remarkably different to the national picture, particularly post-COVID and particularly given the demands on our teams and the levels of stress and complexity that they're working with. In relation to supervision and appraisal, I brought with me Matt Orborelli, who is pivotal in the integration agenda, has worked really hard, diligently across Thurrock for many years. And our supervision rates and appraisal rates are above target, so appraisals are sitting at well over 90% for consistency, and supervision is sitting at 90% and reaches 100% at the end of the month consistently. So really are looking after our staff to then look after patients from a safety perspective. So then moving on in terms of our Better Care Together strategy, in terms of the key areas that we've now further developed. And again, Matt can talk to any of this in a bit more detail if needed. But we've actually got our joint project with Thurrock Council as part of the enhanced Housing First and Complex Housing Intervention team to support local people with mental health conditions who may have challenging housing needs and to avoid homelessness. We're using our human learning systems approach here to, again, really work with individuals to support them with where the key challenges would be for them to avoid them getting into a difficult place in terms of housing. In terms of actually therapeutic approaches, we are looking at, we were able to successfully gain health inequalities funding last year, and we've now taken a cohort of our staff in the older adults mental health team to be trained in open dialogue, which is a whole different approach to working with individuals and aligns with our values around using dialogue and working with individuals right to the point of absolute crisis and continuing to talk and have a dialogue with them and work with their social networks. So seeing the strength of working with communities. So that cohort of individuals is now on their second residential week this week. So they're coming to the end of it. And I have to say that they fed back to Matt and I in discussions, because we're looking after them as they go and as they come back. to make sure that they are enjoying the experience, and any learning they come back with, we share with the team. But some of them have actually said it's the best training they've had in their whole career of 23 years training, and that says something. But this is about actually a whole different approach to working with individuals who are in a mental health crisis. And rather than sending them up to the hospital on the hill, it's actually about working with them in their own homes and staying with them through a crisis. And that is a very different approach and takes a huge amount of demand on our staff as well to maintain that position and not step away. So a huge change in shift and culture there. And then moving on to, we are working with Thurrock Coalition to actually work with individuals in terms of ensuring they maintain access and support and actually resolve their issues locally when they become complicated and things become difficult for them and they feel that they're not able to access services. We are working with the coalition to see how we can continue to improve that, particularly for those that are on our caseloads. In terms of the Better Care Together strategy, in terms of where we are with integration, you will have heard us talk about we have our 4 localities. We are now at a position by the end of March, all 4 of our integrated locality teams, which includes mental health team workers, will be fully compliant with the full stocktake report and what we wanted from our Better Care Together strategy. So already 2 have gone live and the other 2 will go live by the end of this month. And mental health teams are in there in the thick of it with partners, both in terms of being able to have already built really good relationships, set up MDT, multidisciplinary discussions at pressing a button and releasing time to have those discussions, but all 4 of those localities will be in that position. We have done some really good work recently to actually look at how many different opportunities individuals have to discuss an individual. And there are actually over 40 different MDT approaches across Thurrock and Mid and South Essex particularly. We are using those planned care environments to talk about individuals more regularly and ensure all staff are aware about those different forums. But most importantly, using the human learning system approach and building those relationships, we're encouraging and facilitating for staff to actually talk and actually have that collaboration early rather than causing crisis later down the journey. In addition to that, I haven't spoken about the integrated primary and community team. They are the most established across Mid and South Essex and are seeing significant number of individuals and are supporting both with the physical health as well as the mental health side of individuals' care. I'll stop there.
Chair, I need to learn a lesson myself because every time I come to a HOSC, wherever it is in the county, I say we're going to be quick and then we're not because we've got a lot to say. So I'm sorry about that and I really apologise. But I'll really quickly wrap up and say that I hope you can see that there's a huge amount going on. We're really focused on doing things. We're doing so in a compassionate and partnership way. And we've made progress and we're really hungry to make more progress. We're doing so under a lot of scrutiny and there's some difficult stories that will come out about the past over the next year or 2. And one of the things I'm balancing all the time is to take that very seriously and to make sure we're learning lessons and moving forward, but also to retain the confidence of our communities in the service we provide and keep our staff motivated and with us, actually, because there's a lot of competition for mental health professionals. So I hope you forgive me for ending on the positive stories that we're doing. I know this is a scrutiny committee, but there's things happening in EPUT that are starting to be celebrated and noticed. I'm very confident that with the support of colleagues around the table and others across the patch that we will continue to improve and you'll have a service you'll be proud of and your constituents will be proud of in the coming years. Thank you.
Councillor Spate.
Yeah, thank you for a superb presentation, not just well presented, but very informative. It's great to have and I think it is a success story. I'm aware of some of the problems that you face with an EPUT, as you probably know. One of my first jobs as a councillor was dealing with a situation that involved, and it wasn't the greatest output at the time, but it focused my knowledge on the issues that you guys are dealing with. So I've sort of got first hand and whatever. You don't talk a lot about in your presentation about the finances, are you, not that anybody's probably comfortable, but are you reasonably comfortable, or are you facing any significant pressures?
We have been comfortable, and I think I'll be working hard to make us uncomfortable, to be honest, because we need to spend the money on services. I might have gone too far because we're going to have a deficit this year for the first time, but we're planning, and it's because we started to invest in staff in the wards more. And I think that's a success story. We need to get the funding now to make sure that's sustainable, and we're going to get that next year. That's what we're planning to do.
Yeah, I mean, one of the things, it was interesting hearing you tell the story of what has happened with the ambulance vehicle, which is a fantastic innovation, and you're looking for another one. And clearly that's going to be another funding issue that comes along. I mean, and it's great, this partnership you've got in Thurrock is outstanding, and the preventative work that you're doing is outstanding. And it's a good news story that probably isn't as well told as it should be. And the reason I'm sort of focusing on that is I think that there is a great amount of goodwill within the Thurrock community to support good causes, and I'm sure colleagues not infrequently get asked, do you know a good cause we could support? So, I mean, I'm not suggesting we could, somebody's going to come along with hundreds of thousands, but there are organisations within Thurrock that do generate considerable funds, and I think if they were aware of the work that you're doing, that would be, it might only be small amounts of money, but it may be enough, for example, to service a vehicle and put one on the road. So please never feel shy of asking councillors if there's anything we can do to help you, and I'm sure colleagues share that view. But as I know of one organisation that I will now speak to, the local Rotary, who actually asked me that question not long ago. EPUT didn't come into my head, but it's there now. And so, but please, there will be an enormous amount of goodwill to you in Thurrock, I'm sure, and the strides you're making with the local authority are absolutely fantastic. So just my gratitude. Thank you.
Thank you, Councillor Spate. Councillor Polly.
Thank you, Chair. Sorry, guys, I have a number of questions. And I was here at the last time that you presented, and I think, obviously, there was a lot of focus on the ligature situation after the Panorama programme, but obviously there are multiple ways of self-harm, and we discussed at the time that, I mean, everybody's idiom would be to be in a risk-free environment, which is not deliverable. It's not. There is always a human factor, and no matter how thorough we are with our safety netting, there will always be, and especially if somebody's particularly unwell. So, as I say, has all the focus been on the ligatures, or have we taken the eye off the ball on other forms of self-harm? That would be one of the questions. At our last HOSCA meeting, you guys weren't here, but I did mention to Fiona that we've had calls to use the walk-in centre at Basildon, the mental health crisis unit, which is an unbelievable facility. I can't think of where else we've got that situation where we've got 24/7 availability to really senior mental health care workers and expertise, and people that are in an acute crisis are not sitting in an ED department that is not suited to their need, or that. So that I do think is innovative work, and certainly from from the ambulance point of view, because believe me, 111 option 2 is no option. There's a very standard response to, if you feel they're in crisis, take them to the ED department. That is so. There's two things there that I think of merit. We've mentioned about the ambulance car being available 7 days a week. I don't think it is staffed completely, is it? It's not. I don't think it. I think the intention might be to have it 7 days a week, but I don't think we'd be unable to deliver that. So it'll be interesting to know on those numbers what capacity usage of the car it has been. And that's been more of a staffing issue rather than a... so, and in fact, one of the guys in the photograph, I've been on a job with him, literally. So, there you go. But does that replace the police streetcars? Because obviously with the change in the police criteria about not responding to mental health crisis, we've got this fantastic asset now because you have got paramedics in line with a mental health clinician as well, but has this replaced the service rather than a new service? So that would be a question. We've mentioned Thurrock and the joint up-working. EPRs seem to be a buzzword at the moment. I know MSC are sort of... Look, the fact is, you've got NELF, you've got MSC, you've got EPUT, you've got East. We're on Siren, you're on Medway, you're probably on something else at the moment, and then you've got System 1, back to GPs. So that silo situation is still in place, isn't it, when it comes to information sharing? When you, as much as you talk about MDTs and, you know, sometimes you need this, you need people in a room because that laptop doesn't talk to that laptop. So I don't think we're ever going to have that nirvana where everybody can... And this is a frustration for families, this is a frustration for people with mental health and for physical health problems. You know, when they're unwell, when they've got acute long-term problems, chronic conditions they're living with, to then have to go through everything all again, and they're not always well enough to do that. So I don't know if you've got any thoughts about, will we ever get to a system where we don't frustrate service users? You've mentioned other joined up teamwork and community teams, and I know that our actual local area coordinators do a fantastic job, and again with that, the financial inclusion officers, because very often some of the grassroots to some of these people's issues is because of just not being able to function or cope with organising their own day-to-day commitments and things like that. So I just want some reassurance that you know that those practical things are being looked at as well. So sorry, that's quite a list, but thank you.
Just making sure I've pressed the right button because I've got history with these, I'm just going to say. So maybe I pick up on kind of self-harm and suicide prevention, the ambulance car and the police response and how we're working together to address those new ways of working. We can probably between us pick up a bit about the EPR.
Yeah, I'll do that.
And maybe I'll get Rita then to come in on the kind of community approaches. So ligature is the method of self-harm that is most commonly used on our wards by patients who are very unwell at the time. And you see shifts and trends to methods of self-harm. When I was an OT and I was training on the wards, it was often cutting that was used, for instance, that had a real predominance, but we have seen that real sustained use of ligature risk. And as I say, from kind of fixed point to self-strangulation methods, so using items of clothing, blanket sheets, innovative ways of trying to self-harm. So it was really, really important that we got to grips with minimising the risk of fixed ligature and really rescoping the risk around self-strangulation and finding ways to address and manage that. That does not detract, though, from the overall suicide prevention programme, and we have a whole kind of a governance around suicide prevention as well, which is still very much up and running and will still be a key focus in the quality of care framework as well, just to give you that absolute assurance. And we pick up the key themes and trends in methods of self-harm and respond to them, and obviously try and prevent them as well. As far as the ambulance car is concerned, I haven't had any escalations, but I will look out for them and I will go back and check the staffing. The first practitioner, the first EPUT practitioner that was involved in the launch of the service actually then went to work for the ambulance service. So, you know, the collaboration was fantastic, but Claire then went on to work full-time for the ambulance service. So it does need to be a priority for us. It is such an important service. And as you say, when it works really well. So I will go back to colleagues and I will pick up on any gaps and what we're doing about those. So thank you for flagging them. I just want to assure colleagues that doesn't detract from our street triage service. So we do have a service that works with the police control room, and we'll go out on the streets to people in mental health crisis and obviously try and prevent admission, but try and manage that crisis as well. I'm sure colleagues will be aware of the Right Care, Right Person, Right Care, Right Place initiative that is being rolled out nationally. I think it was trialled in Humberside first. We have a very collaborative partnership with Essex Police, and we've worked hard to reduce the number of detentions under 136 as well, and that has happened. We're seeing a shift in the number of 136s coming into our unit, so that is positive. Essex Police have been very clear that there will be no arbitrary undertaking of this, so they will work hard with us on the issues and the risks to resolve them, so that most importantly our residents are safe, but there's a safety in organisations in responding to that as well. There are some real grey areas that we need to work through together, and they include things like response to missing persons from A&E departments and wards, etc. And it will require us all to be round the table to address those issues. We are standing up together a kind of real-time response to real situation incidents where there is a grey area, and any one of our organisations could respond to. But I do think we're doing that in a safe way. We have a strategic group, we have a tactical group with some of our practitioners working on that, and we are communicating with the Southend, Essex and Thurrock Mental Health Strategy Implementation Group, who will be updated regularly on progress. But we are in really regular contact with the police as well to minimise any risks there. And as I say, they have been clear. They won't be setting an arbitrary date and saying this is when we're going with it if we're not ready. You'll probably be aware that welfare was one of the first areas to be looked at. And that has caused some pressure in our teams, hasn't it? I think it would be fair to say, but we are very aware of that and working hard to minimise any risk. Paul, do you want to say a bit on EPR?
I hear you. I just there's three levels to the EPR for us, right? So one is we've got very outdated systems in EPUT, and as I said, there's 7 within EPUT, which creates effectively 7 clinical organisations, and the interface between them is a clinical risk for us. So getting a new EPR, number one, takes away that risk. Getting a more modern EPR means that we can store more data in a more effective way, so people can access it easier, and we can learn from that data as well better. So for EPUT, a new EPR, one of them is better than what we've got now. And I don't want to speak for Foundation Trust, but I'm sure they'd say the same. 3 EPRs across 3 hospitals mean you can't be one clinical organisation. The next good thing about it is that the acute and the mental health organisations in Thurrock will have the same EPR. So clinicians in the FT will be able to see the same data, the same records as clinicians in the Mental Health Trust, which will mean that when people with mental health problems are in the acute sector or vice versa, then we can very quickly get to the root cause of it and again improve safety and improve outcomes. But your main point, I guess, Councillor, is this is an ongoing saga of trying to get a single record in the NHS, which we're never going to get, right? What we are doing is reducing the interfaces here, so there'll be one interface between primary care and acute and mental health, which will make it easier to do a shared care record, right? And that, again, that's a little bit of a nirvana still. We're still working on that, but I think there's an increased coherence, and the fact that both the FT and EPA are working together on this really opens up the possibilities and the understandings more. So I won't promise you nirvana, right? But I reckon I think we're making improvements, right? And I think that will give a better platform for sharing information across those that don't share the same EPR as us.
Thank you very much. Councillor Fish.
Yeah, I've got a couple of quick questions or observations. Firstly, I like the PowerPoint presentation very much. It's very informative. There's an awful lot of information in there. But I would say, as a general point, the sooner that we can get that information, the better, really, before the meeting if possible, so that we can have a good chance to scrutinise it and interrogate it as well. And then the other one was about the access to services. And you mentioned that you're in discussions with the coalition about how you can improve access to services, and you said that thinking of different ways of doing that. Can you give us an idea of what the sort of details of that is?
I'll let Matt talk you through that because he's leading on that.
Thank you. My name is Matt O'Brien. I'm on the service lead for Thurrock locality, so I've been in Thurrock for the last 4 or 5 years. And one of the key successes we've done in Thurrock, and I think it's been a learning for across Essex, in fact, because what we've done is about working collaboratively with other organisations, other partners, in looking at the GPs, what they're telling us in terms of what the patients are telling them. And also we've done various workshops with patients and the family as well to listen to them in terms of what is it that they have been struggling with. And we sat together just pre-COVID and actually look at how do we devise a pathway that they don't have to cross barriers, they don't have to go and see the GP to be referred to services, so that they can actually just ring the surgery and they're booked into seeing the mental health practitioner almost very, very quickly. And the success of that is when we first launched, people were being seen between 1 to 3 days, which was a massive success. But as we're doing very, very, very well and the words we're getting around, unfortunately demands start increasing. And in terms of that, just to mirror and echo to how the success has been, the amount of appointments we offer to the practice in terms of mental health are ranging between 98 to 100%. So that's how the intake or the utilisation are going. That's just echo to how quickly people are accessing. And I think Councillor Hooper was with me as well. A couple of months ago, we had a network forum to listen to people that's using the service as well in terms of what is it that they are struggling with in terms of access. And we've listened to that. We've looked at a couple of cases. We met with them. And some of that is about them understanding to that we've changed the way how people access mental health services. In the old days, everybody would have come to our main community teams. We've now bring it to the doorstep so people can access services at the point of where they live locally. And I think people sometimes feel, actually, when I'm getting to the community teams, the main call, the service was better, but it's not. It's unfortunately more lengthy. So we are learning from that. We are getting good communications to make sure that residents are aware. And we're doing lots of programs, a lot of roadshow around to what mental health offer in Thurrock is about. And for example, some of the key success we've done as well, people that perhaps was very hard to reach community, for example, the travelling communities. We've done a lot of roadshow around that with partner organisations to reach out to these people as well. So these are some of the work we've done to improve access.
Just come back. So it's really encouraging to hear that. I'm really pleased to hear that you're going out talking to people and they realise that you're listening to them and you're getting some good feedback. So it sounds as if you're in a similar situation with the phlebotomy service that we heard about earlier, in the sense that there's an increasing demand. So are you looking at meeting that demand in terms of finance or whatever it would take?
Yeah. One of the gifts we had in terms of, for example, when we look at our transformation for mental health in terms of primary care, one of the gifts we had is that we were able to actually model to what our local services in Thurrock looks like, what are the demands, and based on that we were actually able to recruit on a variety of skill set. For example, not the assessment, for example, the primary care mental health services are not necessarily just nurses. We've got a combination of social workers in mental health. We've got psychologists input as well. We've got psychiatrists helping us. We've got support workers. So we've got a range in order to improve that. So, for example, we can then prioritize what's the best person to see that individual. So that's how we're improving capacity. Same time as well, we are learning to make sure that, for example, people don't have to wait long. For example, we are doing a triaging. For example, if we know that from the triaging of that particular patient, by talking to them in terms of where the needs are, we are rapidly putting them in the right pathway or getting the right services to react to that, rather than them waiting for an assessment to be completed. Thank you.
The other part really is that we are acknowledging that actually for many people, many of our residents, it's actually not that they are struggling with an actual diagnosed mental health crisis, mental health disorder. It's actually lower levels of emotional well-being challenges. It could be about housing, it could be about filling a form, it could be about a relationship, it could be about a child at a school. So the work we're doing around integration is actually developing that awareness and having those conversations. So a lot of the work, so Matt hasn't talked about some of the other work he's done together with the team, where they're actually working with other teams across our 4 localities and linking in with the localities to do sort of training and education about the lower levels and the pathways for those. So people with a long-term condition and multiple long-term conditions may not actually have a diagnosis in mental health disorder, but actually managing, coping with the diagnosis is an enormous challenge. So actually it's about pathwaying individuals in those arenas as well, but also supporting most of our workforce right across the localities to be able to screen for lower levels of emotional change. If someone's not feeling themselves, how do you start to have those conversations and get in early with the community supporting there from a resilience perspective, rather than actually awaiting a statutory response, which may not be the right response for that individual. And there's a bit of a misnomer there. So a lot of the work that Matt and the team are doing is around education and support.
Thank you very much. That's very helpful.
Okay, Councillor Polly.
Sorry about this, guys. Just picking up on that point, Rita, very much so. And I think there's a certain age group that when you're looking at neurodivergence as well, there's many people that have been misdiagnosed with mental health conditions that, they're not neurotypical, so therefore they've been pigeonholed into the mental health category, and their functionality is different. And if you can identify that and get them off of the antidepressant drugs or whatever, then that's a whole new field that's opening up, isn't it? And I think there's a big recognition. So sort of people 30 and over have been living a life that and have been coping for so long to fit into a world that isn't natural for them. So I very much hear the challenges that you've just brought to us there. And if I can go back to EPOT, sorry, but you were saying about doing the piece of work from 2000 to 2023 on, and the framework that's going to cover is still being developed at the moment. What challenges will that be, because you've not been EPUT for 23 years, have you? Was it set before EPUT? I mean, how difficult is that going to be for you to actually cover that period of time? Thank you.
Yeah, well, before the statutory inquiry was an independent inquiry covering a similar time period, and they've converted it to a statutory inquiry. It is really challenging, right? We've got to find data for 20 years, and mental health services were very different 20 years ago. You know, we still had institutions open, and the way records were kept were very different. We've got a good trawl. We think we've got solid data now for the last 23 years. Clearly, the accuracy and the completeness of that data is better the nearer we are to present time, and we hope to be able to serve the inquiry well. The biggest challenge, I think, well, there's two challenges for us. One is to make sure that data is available to the inquiry, and that our staff are available to the inquiry as well. And the other one is to keep our staff and our communities confident in delivering the services today as well.
Thank you very much, Paul, Alex, Rita, sorry, I can't. Matt. Thank you very much. And Mark, I've got you too. Oh, right, okay. Right. Thank you very much. I actually have lots of questions, but I'm aware of the time.
Sure.
So I may email you my questions.
Absolutely, yeah.
Okay. Yeah. I'm particularly interested in healthcare prevention, people not going into hospital and those community services, and also making sure that information is going to the right people when people are discharged, making sure GPs get information, because I know that's been an issue in the past. So I know, Paul, you have picked up a hell of a challenge. And I really thank you for the work you're doing. I know there's a lot of challenges to come, but if Thurrock can help in any way, please do let us know.
Thank you very much.
Thank you.
Thank you.
Chair, are you okay if we leave?
Yeah, yes. I'm just actually thinking, we've been here 2 hours, it'd be wise to have a comfort break for 5 minutes. So would people like a comfort break for 5 minutes? Yes?
Yeah.
Right, so if we have a comfort break for 5 minutes, please. Okay. Are we all ready to restart? Excellent. The last agenda item was for 15 minutes. Was on the agenda, and that was slightly over an hour, but I felt nevertheless important to have. So I'd like to press on.
We've got to extend.
I may have to extend. But I'm not at that point yet. It's about 9. I think it by 9:20. Would I need to extend?
About 9:15.
About 9:15. So I'll bear that in mind. Okay. I do want to get through this agenda today. Right. So if we move on to item 8, integrated health and wellbeing centres, coalition options across Thurrock. So Alex.
Thank you, Chair. So I'll take the paper as read, and hopefully you found some details of it helpful. I would like to make a point of correction. I believe on the page 2, I've referred to underutilisation of Corringham. So at the time of writing the paper, we had still some clinical rooms vacant in there, but currently I'm pleased to report that we actually got 97% of the premises utilised, and we are working very well into utilising the agile spaces upstairs, which, if any of the offices were there this week, was actually quite vibrant. So I've provided you with an update around the history of the IMC programme, how far we've managed to push forward. However, I've also outlined the obstacles that we've faced, and those are around ability to find suitable capital to progress with a number of schemes. I've indicated here before that we had funding challenges against those, and I can now confirm that NHS England has formally rejected the business cases against Purfleet and Tilbury. So as much as it's disappointing news, we continue to work with the system partners to still deliver the assumptions and the integration that we committed to in the Better Care Together Thurrock strategy. What I have tried to outline in the paper is a number of opportunities that are arising from that cooperation, particularly around utilisation of void spaces, which you have had in the latter part of the report. I spoke about the INTs and transfer of care hubs, and again that links to the pieces of work that Rita and other colleagues already discussed earlier today. We've got opportunities arising from community diagnostic hubs, the recruitment of ARS roles, and the education capacity that we brought into the system, as well as GP fellows. So I think that's a whistle-stop, if you like, bearing in mind the time, but I'm happy to take questions to any part of the report.
I can't say how disappointed I am. I cannot say how disappointed I am to hear this news. This has been a plan for 7 years, and to find out 7 years down the road that we are not getting the integrated medical centres that were originally planned. My understanding, I want some clarification really about why 7 years down the road NHS England have told us that this is not a workable plan. I also want some clarification on the Grace site and why we can't go ahead with the Grace site. Is it reliant on the sale of other assets? So I'll just start off with that point.
Of course. So I'll take those in order. NHS England did not take 7 years to give us a response. The business cases were produced over the last 18 months to 24 months. They have been with NHS England for about a year now. Hence, we've received the reply. I think we need to distinguish the inception of the plan and the concept, then the fact that we tried to build the business cases, and there was a chain effect between them because we were discussing and delivering a number of schemes. Corringham was delivered in that time frame. The two that I just quoted on Purfleet and Tilbury were the last ones in the chain, and those have failed to secure the approval of NHS England. In terms of the Grace site, the inception of IMWC at Grace was always predicated on sale of Orset. Again, during the 7 years, a number of strategic decisions have changed. We've obviously spoke earlier on about the backlog, our lack of ability to sustain capital investment into the broader system, and as well about the impact of the pandemic along the way. So I think there's a multifactorial reasons why we weren't able to progress with that, and hence this is providing the difficulty in progressing with this particular site. However, hopefully, as I've outlined in my paper, we do have the benefits of the CDC, which is something that we weren't aware of 7 years ago. So we are really trying to capitalise on opportunities of integration around those premises.
Whilst I welcome that, it's not near my WC.
Indeed, and I think I've tried over the last couple of months come here and quite transparently outline the challenges that we all faced as a system, but also be very honest in explaining our approach to any plan Bs that we could produce. I appreciate that plan B is never as good as plan A, but I think also with the financial situation that we're facing as a broader system, we need to be able to utilise all the premises available to us. And there's been a huge amount of work between council colleagues, ourselves, EPUT and NELF to identify void premises in the area, and we feel that from taxpayers' perspective it is our duty to utilise those before we put another huge investment, considering we don't have money to do so.
I've never got my head round why we've got this plan and no money in place to deliver it. I really cannot get any business couldn't survive on doing that. So should the business case should have been originally put in 2016-17 when the plan was concepted?
It's very difficult for me to answer that, Chair, and that is because I was not part to these decisions. It was 7 years ago with a number of other colleagues being around the table. I think the reality is that there was meant to be a chain of business cases, and one was affected on one. Sorry, the inception of one was then meant to create another, and unfortunately, pandemic along the way, as well as lack of capital investment, prevented us from being able to produce those.
So I'm assuming that we're not going to get the centres we thought we were going to get, and that means that Orsett Hospital will remain open and kept to a high standard, as was part of the agreement when we looked at the 4 medical centres being set up. Will that be the case?
What I could say is that we are working across the system with partners to deliver the benefits of integrated wellbeing centres through utilisation of existing buildings. So we are still committed to Better Care Together strategy and to delivering the benefits arising from co-location and working together. However, these plans will be different to those initially proposed to you back in 2016-17. I think also rightly so, population needs have changed. People work differently, so I think we need to be able to deliver services in a very different manner than what we would have done 7 years ago. In terms of Orsett, we've spoken to MSCFT as the Trust holds those premises, and we've got reassurances as well, as per my paper, that this site will remain open until any other suitable capital will become available to us to propose any other changes or movement of services.
Well, I assume that will mean keeping the building in good condition at Orsett Hospital.
We will maintain the building in as good condition as possible with the funding available to us.
I might have other questions, but I think I'd like other councillors to ask questions. Who would like? Councillors. Councillor Polly.
I have grave concerns about the ICB in their involvement in this, because strategic operational strategy had always supported these IMCs, and to say that we didn't have an operational business case previously, we've had the goalposts changed, but we have had business cases approved, I believe, on the Tilbury one previously and the Purfleet one. Prior to this chair, I sat on this committee previously, and the vice chair then, Councillor Holloway and Councillor Ralph, had reassurances. In this report, we refer to memorandums of undertaking. We've been told for 7 years that Orsett wasn't fit for purpose. We're now sitting here tonight saying that we're going to keep it open. I don't know where you can expect us to have the confidence now, because this is, as I say, I think the ICB is a very unchallenged board. I do think that the governance around how it operates and how it sits within the MSC is something that needs closer investigation, because I don't see how all the partners round the table have all been working to the same goal, and it now has changed in a matter of 18 months at the most. There are probably questions you can't answer, but I do think that we might need to look at that as a challenge for HOSC to actually get the ICB in to see how their strategies are not in alignment with the foundation trust that they sit within. That is a concern. But on page 32 of the report, we've got reference to void and primary care space in Thurrock. We've again had Stifford Case Health Centre bandied around for a couple of years as possibly even an alternative site for the IMC at one stage. So, and I know during the pandemic we had quite a big vaccination centre and that there, but it certainly wasn't, floor space capacity to cover the services that were meant to go into the Long Lane. As regards South Ockenden Health Centre, I've actually spoke to GPs that operate in there, and they say there are accessibility problems with that building, that the capacity is upstairs and accessed by a spiral metal staircase. So, again, we're coming into capital expenditure, building fit for purpose. I mean, that building was built in the 50s, 60s. I struggle. I don't know that those being referenced in the report are credible solutions. I know there's many more questions to come, so I'll stop there, Chair. Thank you.
So I'll respond to those in order, Councillor. So just to confirm that the business cases for Purfleet and Tilbury have not previously been approved by NHS England. So I can put that on record, and that those have, once submitted last year, have now been formally declined. In terms of the MOU that we've referenced, that is obviously still in place, and the assumption of that was that OSET will not be closed until we provide the services elsewhere. Therefore, we are still effectively not in the breach of that MOU. In terms of the confidence comments that you make, the programme around IMWCs has been managed through the programme board for a number of years. There are representatives from the council, from estates teams, from EPUT and NELFT on this programme board, and they were fully cited on development of these business cases. They were also fully cited on challenges that we faced in terms of affordability, which I've alerted you to back in the summer last year. Feedback from that, again in line with our place-based governance, has gone to TICA, which is our Thurrock Integrated Care Alliance board that myself and Ian are co-chairing. So again, when we face those, we've brought those for further consultation with the updates to TICA. We also, from personal perspective, I wanted to be open, honest and transparent, and as Councillor Spade said, it's important that we have even difficult discussions in these forums. I did not want to sit and wait for the decisions to be done to us. We've worked hard with Ian's team and other partners to provide you with that Plan B. I appreciate Plan B isn't always as great as it might sound, but with limited resources that we've got, we tried our best to utilise what we've got. The South Ockenden, I'm quite happy to discuss the accessibility issues outside. We are aware of the staircase that you're referencing, but we've also spoke to the current occupiers that we could move the services around in order to allow access on the ground floor to different services and have administrative staff upstairs. So we have considered those, but that is work in progress. And as per my paper, we are now extending our request for further cooperation to EPUT and NELF to be able to see the breadth of the premises that we've got across Thurrock. There is a request for yourselves as our councillors and politicians to help us secure more capital going forward. We absolutely want to invest more and more, but it's just about being able to work with the constraints of the reality that we're operating now. So hopefully that gives you some reassurances on governance, if you like, that we have done this in conjunction with the colleagues.
Thank you. We have got this fellow come to him and Ian in a minute about representation.
Sorry.
About the request for representation for capital funding. I was asking you for a comment on the business cases as well. Am I mistaken in my comments, Ian?
It might be helpful just
So the answer to that is yes. The business cases were submitted in 2022. We waited about a year for NHS England to make a decision, and they finally made a decision just before Christmas, and that was communicated to us. But there have been no business cases approved before that. As someone who's been involved in this pretty much since the start, and I think one of the few people, just some observations. So, firstly, I completely understand the disappointment and the anger and the annoyance of this committee, and you're right that you have received a series of assurances over the 7 years about commitment, and that hasn't come to pass. In terms of the reasons for that, I think one of the challenges we've faced as a council is the repeated staff changes from the NHS side. And in the same way that the committee recognised that Paul Scott inherited a significant challenge not of his making and was doing his best to try and address and improve it, I do have a huge amount of personal empathy and respect for Alex, because she's come in at the 11th hour and inherited something that's gone on for 6.5 years before she arrived, and has been subject to a whole range of assurances from a whole range of very senior people who now are no longer part of the Mid and South Essex and Thurrock system. We've had an organisational change challenge as well, so we've gone from a Thurrock CCG, where I think we had quite stable staffing and a really strong relationship, to a national reorganisation that merged it into 5 CCGs and a STP that then merged that into an ICB that then restructured itself at the direction of government, and I think that has exacerbated the instability on the NHS side. We then have another body, NHS England, that makes the decision on the business case itself, and clearly that organisation that is the decision maker is not in the room to account for its decision, and we've had very little communication or explanation as to why. And then my final observation is that the NHS nationally changed its rules and how it deals with capital and how it applies that to revenue. It's something called CDEL. There are people far better qualified than I am to even attempt to try and explain the CDEL rules. They are complex and opaque, but it suddenly caused an affordability on paper issue, because it didn't the business cases didn't meet the new formula on the CDEL limit that is applied to the ICB, and I think all of those reasons have compounded the unhappy situation that we find ourselves in now. From my point of view, I just wanted to reiterate and support Alex in our joint desire, I think, to try and find something that's salvageable moving forward. And it clearly isn't going to be an IMC, but we have jointly with the ICB, Sir Sarah Carey, who is an excellent officer who works for Kerry in conjunction with Dave Marshall from your estates team, have done a appraisal of our joint estate in Thurrock. There are a series of options that came to the Better Care Together executive on the last day before we broke up for Christmas. We've identified space that could be refurbished in buildings in Purfleet and Tilbury. And actually, in the workshop that I chaired this afternoon, there was another option put forward. So we are delegating what was the estate group for the IMCs, the task to look at that. We have some capital funding. I know the ICB has some primary care capital funding, and I think there is some parked money with the council that we may be able to access in terms of refurbishing that estate. For me, the most important thing is actually collective and collaborative space for the integrated locality teams to operate from. So some of the excellent work that you heard Rita Thakaria talk about and that we've presented to this committee and the Health and Wellbeing Board before. For me, that's where the real innovation sits, where we can bring different teams together to form relationships with each other and with residents at locality level to deliver that human public service and that integrated response and that bespoke response. That is what is going to fundamentally make the difference in preventative and early intervention and care. And we have to have spaces for those teams to operate from. You can't do that in silos. You can't do that on MS Teams. It has to be different staff groups coming together with residents. So I'm determined that we will find that space and we will refurbish that space to a high standard such that those teams can operate. And we're working very, very closely with Alex and her colleagues to try and salvage something from this.
Councillor Spate.
Thank you. Councillor Hooper started off by saying that he was disappointed. Mr. Waite just used the word angry. I think I sit somewhere above that. I think the word is incandescent. And I would preface that by saying I have absolute confidence that Ian and his team will make a silk purse out of a sow's ear. The department within Thurrock has shown such innovative work in trying to cut down, effectively dealing with things before they happen and whatever. So, and they're coming from the health problem from the right way. They're talking about prevention rather than cure, if I'm trying to sum it up. So I have absolutely no doubt that they will make the best of an appalling job and that they will give us a service that will be decent, that will help the people of this borough. And I'm sure that we as councillors will support the team in as much as we possibly can, and we'll come up with ideas and we'll speak within our communities as these buildings are identified and whatever, and try and win people over. But I think before we get to that, we have to have an inquest into what has gone on. And we have to play the blame game. And people may say, well, you're being petty, you're playing politics, you're doing this. Well, I'm sorry. I've had 7 years of watching people play politics on this issue. And I've got in front of me a couple of media sites, and none of which are connected with me in any way, shape or form. And it says here in 2018, and I quote Dame Jackie Doyle-Price, not a dame at the time, but it says, and this is really pertinent, the decision to close Orsett Hospital and relocate its services to new integrated medical centres in the community is one that has been taken by the NHS. This was not a scheme dreamed up by Thurrock Council. It was a scheme that was brought to council and politicians by the NHS. It's there in black and white. She says, I feel very strongly that clinicians are better placed than I or any other politician to decide what is best for patients. For that reason, I am supporting this decision. She then talked about Orsett Hospital. The facilities at Orsett no longer meet appropriate clinical standards. This is 2018. I have spent a lot of time there over the past couple of years, and it really is time that the people of Thurrock were able to use modern facilities and for staff to work in better conditions. It will be to the benefit of patients across Thurrock that new facilities will be located where people live, in Corringham, in Tilbury, in Purfleet and in Grays. That's her words. And we've seen reams of, and I have to say it, I don't particularly want to be political, Conservative politicians lining up and standing behind that flag. And I moved to the other quote in 2020, when Jeremy Hunt, the Secretary of State for Health, came to Thurrock and stood alongside Jackie Doyle-Price and talked about what a great idea this was. And this scheme that it was going to change the thing. And he was delighted that Thurrock Council, Basildon Hospital and Thurrock CCG, and I accept that's no longer with us, have stepped up to the challenge and are delivering these new health centres. I know some people are nervous about the closure of Orsett Hospital. I think we were more than nervous then, and we've been proved to be right. You can talk all you like about failed business cases and whatever, but we have been told as residents in this borough, what is best for us by the people who are best placed to do it. And those people, within the NHS, within the political hierarchy of this administration, they are the ones that now need to be held account for failure. And failure of a magnitude, it might not match the level of losing £1 billion, but it is a massive failure and an example of politicians lying to the people of Thurrock. And I don't use that word inadvisedly. They have lied about what they're going to deliver. I think we should be calling as a council for a public inquiry into what has gone on, because as Mark made a point, he can't get his head around, and he's a very clever man and works within the health profession. He can't get his head around why this has happened. I haven't got a clue, but I'm nowhere near the brains that he is. And the people of Thurrock want to know some answers to these questions. Why have we been shafted? Why have we been lied to? Why have we been cheated? And why are we going to have to do with, however good it may be, second best? They're questions that we need to put to rest. And I hope that this council and its councillors and the electorate and the people in Thurrock, you know, demand some answers. But I will also ask you a question. I keep being asked about, you know, I've read your report, things have been better. You said tonight about Corringham being optimised and whatever. I've been to the village hall next to Corringham's IMC on at least 3 occasions in the last couple of months to go to meetings. Corringham IMC is blacked out. And I'm talking about 6 o'clock, 7 o'clock at night. It's blacked out. It's not being used. It's empty. The car park's empty. The building has got nobody in it. So this fantastic building that we built, don't tell me it's been optimised, because it's not. It's shutting its doors at whatever time it may be, 6 o'clock, 7 o'clock. Why is it shutting its doors? Why is it not running into the evening, offering services for people who are at work and need health care, who need support from the teams that we've got? Why isn't that building open in an evening? It's an IMC. It's the only thing we've got that's new, and it's nowhere running near capacity. So before we can even trust you to move on to other things, please get Corringham right. Why is it not working?
So I think I'll start with Corrigan, but I might pass on to Rita because she's much closer involved in managing the site on a daily basis. I think Corrigan being our first site has also brought us a lot of learning. It took us much longer than expected to be able to get to the optimal model, and we have taken that learning on, and we will feed that into the next stages of our work. It took us a while to fill in the clinical rooms, but we have significantly progressed that over the last 12 months since we've opened the site. Good work takes time, and it takes time to build those trusted relationships, and that agile working space has enabled us to do so. We have brought in voluntary sector to work with us. I think your questions are valid, and I think there's nothing stopping us progressing further with this site, but I think it's a staged approach, and you always start with emerging, then you move to maturing and developing and maturing stages. So it is a journey as well as with anything. It requires staff and it requires planning. So again, we need to put some safeties around ability to work to the later hours. Rita, is there anything else that you want to add to that?
Absolutely. So we are at 97% occupancy in terms of all the different offers that are available within that building. So that's both clinical services, and then all the other offers that we have from there in terms of the group rooms being used, etc. In terms of the space upstairs, the agile space, there are days where actually you can't get a seat now at all, and Ian was there earlier this week. And then, of course, there is a change in footfall throughout the week. You'll see community nurses coming in at lunchtime for handovers, but community nurses are out seeing patients, and that's where they should be out in the community. In terms of the extended hours, that is a valid point, and actually that was always the expectation long term, to have the extended hours and in fact to have opportunities at the weekends. However, what we're faced with is last winter we had the acute respiratory hub on site prior to the primary care teams being established within the IMWC. So last winter we had the evening offer and it worked really well. This year that offer isn't available. So the services that we have currently are those established historical services. So if we were to move those staff into offering the evening sessions and the weekends, we'd have to reduce the footfall during the week. So it's about redistributing the resource through to the evenings and the weekends. But actually you're absolutely right, that was always the expectation of that building. and it's the next conversations we're having with the Alliance and partners in terms of how do we make that happen. Certainly what we did see is the evening clinics actually were successful, and you're absolutely right that for people that are working, it worked really well for them to come into the evening. You will see community nurses and other professionals there in the evenings, but they're using it as a safety base and a base to actually come and do their write-up of notes before they go back home in the evenings from about 10 o'clock.
If I just may say, I mean, we've got a built-for-purpose phlebotomy centre at Corringham. We spoke earlier on in the evening about the lack of capacity and about what we can't do. Well, we've got a purpose-built building to do phlebotomy that shuts its doors. And, you know, I get your argument and I understand it. But Joe Public, of which I am one, just says, well, why can't we have 3 or 4 nights a week, why can't we have a phlebotomy service operating from a purpose-built building? It's so blindingly obvious to the ordinary person in the street. We can't get our heads around why the NHS can't get it.
I'll just respond to the phlebotomy. So we've actually increased phlebotomy at the Corringham Integrated Medical and Wellbeing Centre, and that is moving around some of our resource in terms of the NELF phlebotomy. So actually, again, today, if you'd come to Corringham, you would have seen that we've now got the ability to have extra phlebotomy appointments because NELF are providing it as well. But I totally support your point that in terms of phlebotomy, it's a really good opportunity to use it for weekends and evenings as well.
So could we come back with something a bit later, maybe in our March meeting, about how we're going to extend that and what are potential funding issues, if any, around making that happen?
Absolutely, and in fact group rooms as well, because for community groups as well, those rooms are available for evenings as well.
Councillor Fish.
Thanks, Chair. I share everybody else's disappointment and anger about the problems with the business cases being turned down by NHS England. I do think that the Plan Bs, it was quite clear to me as then the shadow portfolio holder 18 months to 2 years ago that those Plan Bs were going to be necessary. So I'm not sure why our portfolio holders since then haven't been working on those and actually producing some kind of results. But the other thing to say, though, is that I do remember when it was mooted that Alston Hospital might close, the amount of public support there was. I think something like 75% of people said that they wanted the hospital to stay open. And since then, all we've seen is a decline. From what we've heard tonight, there isn't the capital money to keep it up to the standard that it really requires, only money for critical repairs. So I really struggle to have any confidence that Allsit is going to actually thrive in the future and be there for people when they need it.
I think, again, points well made, Councillor, and as I said, we were really, really keen to bring you a Plan B, which you've requested for a number of months. In terms of the maintenance programme, as MSCFT colleagues have outlined, that is an ongoing challenge across the board, and the Trust is doing everything they can to get hold of more capital from the government. If there's anything else that we can do to influence that politically, that would be much, much appreciated, because we cannot do this on our own.
I was quite encouraged with what Ian said about the what they're working on. The bit that I didn't hear, though, was that patients and people that might use the service will be involved in that at an early stage. So I'd like to hear that that's going to happen as well.
Yes, absolutely. I think we're not at the stage. I'm very conscious, particularly in terms of what's been said this evening, that we don't make any more promises to anybody until we are clear that we've identified the sites and the capital is available. But I think from that point, then we have a long tradition of really good patient and resident engagement and consultation when designing all of our new services, and that would continue in terms of this as well.
Councillor Piccolo.
Thank you, Chair. Yeah, I'm a little bit concerned about some of the language that was used a bit earlier on. With regard to the hospital, you say, while it's cost effective, and the also maintenance, upkeep. It doesn't say Allsip will stay open regardless. If you run out of money for maintenance, or you can't find the money for maintenance, that basically says Allsip will have to close. I mean, what guarantees can we have that there will be funding to make sure that Allsip stays open in a safe manner for people to use until it can be closed because the other facilities are available? And just one, perhaps in hindsight, I mean, this was come out 7 years ago. I say, in hindsight, would it have been a better idea to perhaps get the nitty-gritty sorted out first, or get closer to seeing that it is financially viable and that it can go ahead, rather than put the aspirations into people and the public's mind of this fantastic service that's going to be right on their doorsteps, going to save them travel, and then 6 years down the line or 7 years down the line, it's suddenly the rug's pulled out. So we've built up people's expectations, and I think that's one of the big problems about this.
If I may reply, Chair. In terms of what guarantees, you've got guarantees in this paper that ORSET will remain open until capital becomes available to relocate, potentially propose any other relocations of services. So that's the assurances I got from MSCFT Trust, who own the site. I can't predict the future. Will we get any more capital as and when? We are, again, seeking your assistance in trying to get as much of that as possible. In terms of the hindsight, if one knew it was going to fall, it would sit down. So it's really, really difficult for me to comment. This, as Ian said, this all predates many of us in this room. What I really would like to do, and in my time in Thurrock to date, was to be open and honest and transparent with you, both about challenges and opportunities, and I've committed to come and tell you the truth, and I have so far, as much as it cost me a couple of scars on my back to date. And I'm openly telling you that you've asked for Plan B, and that's the Plan B that mine and Ian's teams are working up together. So I understand the expectations that were raised, and we've clearly not risen to those, but we are committed to do better going forward as an alliance.
Thank you. I just wanted to say, because most of our work is spending time out in the community talking to residents, but also my job means that sometimes I'm sitting in meetings that, like this meeting, and like Ian said, there's not many of us left here who was at the beginning. In 2015, in the church, in the school hall in Tilbury, with Mandy's "Build It and They Will Come" and all your doctors and nurses. That's where that started, and there was a whole room of the public who have sat on that believing this is coming. I've been out there talking to people over the years. I've been asked to do pieces of work with them about the closure of Allsip, which has actually needed us to have tin helmets on, because we were seen as not that independent person, but somebody that was about to start doing that work. People still talk about the Hog Lane promise of that community hospital that fell about. They remember that. So I think what Councillor Fish said is right. People should now be right in on this now, not keep pushing them back and telling them this and telling them that and writing another paper and something else. And also I want to say at some of those meetings I've sat in over those years, the amount of money that has been spent on these IMWCs that never came must be colossal. There has been architects, there have been plans, There have been drawings, that's all gone back, and then it's come out with more plans. There's been project managers hand over fist. There have been people who are paid a colossal amount of money who have sat there and decided how much space they want in this one and how much space they want in that one and where they'll deliver this and where they'll deliver that. And it's a shame that it's all come to this at the end. But the thing is, people out there need something. The people need something, and they need to be involved in whatever is next. They need to be part of the plan. Somebody needs to stand up and be really honest and go, look guys, we know you were going to get this, but you're not getting it now, and this is the reason. Because the majority of people out there truly now believe that the reason they're not getting them is because of the trouble, the financial situation that the council are in. They're not even looking at the NHS, that it's their fault in any way, shape or form, or that they can't come up with the money. It is just, well, council spent all of our money. And the sad bit about it all, as I'm going to finish on, is, you know what, most of them never expected it anyway, because they never get anything. That's their words. And I just think that needs to just be thrown in the pot as the reality as well.
If I may, just quickly.
Can I just stop for a moment?
Yeah.
Because I'm aware at the time that I technically have to ask for an extension.
Agreed.
Okay. So can I have an extension till 10 o'clock? Is that agreed?
Apologies, Chair. I'm actually covering the system on call.
If I may, Kim, I recognise many of the comments that you shared, because I too, and so my Alliance team, is being the delivery arm of the Alliance. We do spend quite a lot of time in the community. What I hear from people is that Orsett Hospital is a much-loved hospital. I hear how many people were born there, how many people have mums working there as nurses, or who became nurses because their mums have served their life, working life in there. And I think it's important for people. You said people need something. I think people need services on their doorstep. Not necessarily we need to be. I don't think it's our job to determine the size or shape of these buildings. I think there's learning as well from what has happened in those 6 years. We had grandiose plans. We've wanted the biggest space possible in the nicest shiny colours. Yes, we needed architects to help us draw that, but I think we need to have further conversations that are driven by the needs, by the need of population, and factoring that the world has significantly changed, and by that I mean through pandemic, our working patterns are different. Rita spoke about community nurses. They're not in the office 5 days a week. Plans were made based on 5-day-a-week working offices rotas. So I think that's the learning we need to take going forward and utilise that in the buildings that we've got left to us. I think no one in the system is in a privileged financial position right now. ICB, EPUT, Council, we all struggle, but I do think we've got duty to the public pound to look at it twice before we spend it. Therefore, I do believe we need to look at the void spaces first.
I absolutely agree. It's not a problem. I'm not saying it shouldn't happen in the hospital. I'm just saying that we need to really be honest and upfront with people and take them on that journey now.
Okay, thank you. Councillor Tandy?
Yeah, we talk about capital funding. Obviously, that's the main issue here, whatever we're going to progress with. In previous years, when does the government tell you, NHS, this is how much you're going to get? Do they do that at the start of the financial year, or is it you just don't know?
This is quite a complex question, but I'll try to simplify this as much as I can. There are certain capital allocations, like for primary care, that we do have on an annual basis. And there were, for example, previously STP capital funds that were given to us by the government. But also, as MST colleague said, there are those drip and drabs of funding that are being available throughout the year. So there isn't a straightforward answer to your question. The capital that the Trust currently has available to them is the one that they've explained the allocation of in their paper. And that is what they currently hold. That's what's available to them. It's a bit complex, I'm afraid. It's both ability to obtain the funding, as we said, and then, as colleagues explained, it's the ability to utilise that in a timely manner to both repair, maintain, change and shift, or to build. And obviously there's a significant implication in the recent years with significant cost in the building costs. So everything that we planned in 2016 and 17, those costs were estimated in certain figures. These figures now are higher by 30 to 50%. So again, that shows you the size of the challenge that we're up against. That's why we're asking for any help in obtaining more capital.
So basically, you're competing with nearly every hospital in the country, and they bring their project to them and say, and basically ask you who needs it the most, and they decide.
Indeed, and as Fiona mentioned to you, we're asking for 100% of what we think is necessary for us as a system. We're getting about a third of what we really need. So we're always playing catch up.
Councillor Spate.
Yeah, I think Kim's was the most heartfelt things that have been said this evening, and I go back in the same way. I remember standing in the Civic Hall with some eyebrow woman on an exorbitant fee stood on the stage and told us we were going to get Nirvana. But let's talk about what we can get, and we know that we're going to get. We know that it's going to be 2 or 3 years at least now till all this rolls out. So it's almost certain that Orsett Hospital is still going to be the centrepiece of healthcare in Thurrock. We've got a table put before us earlier this evening that talks about backlog risk summary costs. It says here that Orsett Hospital's high risk is going to put it right, to get rid of that high risk is going to cost £4,118,154. Now, we know, everybody in this room knows Orsett Hospital is still going to be functioning in 4 to 5 years. So at the very least, that the NHS or the government should, by way of an apology to the people of Thurrock, is make an apology by writing a cheque for £4,118,154 so those high-risk problems at Orsett can be fixed. Because we deserve that if we don't get anything else. So can you give us an assurance that you will go back and say the people of Thurrock deserve not to go to Orsett Hospital and be put in a high-risk situation? We can suffer significant, moderate and low, but it ain't right that we're going into a high-risk situation. And that's a fixed amount of money. It's on your chart in front of you. I think we should go and ask for that by way of an apology.
I am all up for any joint efforts in making influence upwards the chain for asking for more money to support services in Thurrock. In terms of the risks identified in MSCFT's paper, there is a risk stratification procedure that the Trust is following in order to address those high-end risks, because maintaining health and safety on those premises is important. Otherwise, they would not be able to operate. So I'm not a maintenance expert. Happy to, again, have a further conversation with Jamie and Fiona about this. I take your point, and I think it's a valid one. We are doing what we can to maintain this site in a health and safety compliant state.
Are there any other questions from councillors? Councillor Polly.
Thank you for allowing me to indulge me, Chair. Alex, I am going to say thank you so much, because this must feel like coming into a lion's den every time, and you do show up and you do face the music, and we probably don't appreciate all the work that you with partners are doing in the background. So I do apologise perhaps for some of the attacking comments earlier, but as we've all said, it is a frustration. So we've got to start looking forward. I understand Councillor Spate asking about an investigation and internal inquest into why NHS has not seen fit to continue with this. I'm in conjunction with the Chair, perhaps if we have a speak. One of the arms of the Overview and Scrutiny Committee is we have got the power to actually call for witnesses. So there might be an opportunity for us to get that NHS person in the room, the one that has actually signed off and said it's not going forward, and let them face the music for a bit. I don't know how the rest of the committee feels about that, and that's something we can perhaps... So that, you know, the questions that Councillor spoke, quite a good, you know, I agree totally. You know, we are all residents of Thurrock as elected members. We live here too. These are our families and ourselves that are you know, expecting these services. The other concern that I do have, as we as an authority are going forward with our local development plan, site allocations have been identified for these centres. What I have a nervousness about is that we may, by saying they're not going to happen, that we might lose those land parcels, and we need. So I think we need a little bit more meat on the bones, and that's not something you can do standalone, Alex. I'm not firing that at you. I think collaboratively we need to speak. You know, we take advice from you know, Ian, who's you know, obviously got chapter and verse on this, and portfolios, and again with yourself, Kim. You know, there's monies that have been secured through sections 106. There's things like that are being ring-fenced to support these projects, and though we can't jeopardise that, so I think that's something. I also have a concern because it's not just the physical buildings. I mean, the people that are delivering the services already, the people, I know we affectionately refer to it as Allsick Hospital. As I say, it's not been a hospital for many years. There's not bed capacity there. But there are staff there. There are people whose jobs and livelihoods are being bandied around. 1 minute are we staying, are we not staying? That you know, as well as the residents and that, I think, you know, there's some concern over will they still be there, and the fellowships as well. You know, we're underprovided with GP services. Part of the sort of soft infrastructure that the IMCs would provide in addition to the physical buildings was this was supposed to be the shining star that was going to attract these newly qualified GPs to come and work in Thurrock to backfill that short gap. So again, if the message is going out that they're not going forward, where does that leave it with us with those fellowships? Too many questions for you to answer, Alex. But I do think that, you know, again, we've asked you in the past, what can we do to help you? You've been very clear. We need to make representation to Minister about the strength of feeling, and I would hope that we as a committee can put perhaps something to portfolio holder to help us support that. I don't know if you'd be in agreement with that.
Certainly be willing to talk to the portfolio holder and take look for a way forward.
Shall I respond? So firstly, thank you, Councillor Polly, for the thanks, because it's been indeed a huge team effort across the partners to be able to produce you some way forward. So thank you for that and acknowledging this. In terms of the local development plans, I've already spoken to a number of colleagues in the council about that, and we want to ensure that we are, again, talking in a timely manner about opportunities arising from that. There is an infrastructure strategy that is being drafted in ICB, and so is with EPUT. So again, we want to be able to, through the partnership that we've established through alliances, have one conversation and make the best use of the collective estates across the board. In terms of the staff, as I said, I'm well familiar with the sentiment, and I'm one of those directors who's very keen in putting my trainers on and trotting across Thurrock to get to know my services. And in the times that I'm spending in Offset, I often hear those questions about what's happening to us. So I also feel that today, as disappointing that it is, it will give people some clarity that we can stay and continue and try to work with the staff to give them the assurances that they needed for a long time. In terms of the fellowships, again, this is also covered in the document shared with you. We currently got 6 of those in already. I do not think that lack of IMCs is going to detract people in coming to Thurrock. Hopefully, William will confirm as well. We had really successful recruitment into the number of clinical and non-clinical roles in the recent months to Thurrock. The fellows come in here because they want to gain more speciality knowledge that is aligned to the work they're doing in specific GP practices. So lack of the buildings is not going to stop us progressing with that. We've recruited over 80 additional reimbursement roles, of which you've got paramedics, you've got physician associates, you've got nurses. Thurrock's recruited most of them across all of the 4 alliances. So I'm very proud to say that we are continuing with our efforts of recruitment, and we're not going to stop until we're in a better place.
Okay. Professionally to make this happen. But I just can't let it go. I think people need to be held to account. I think we've been lied to, misled, conned, and the state of Thurrock Hospital is in a really sad state of repairs, which I think is unacceptable. Back in 2017-18, the Tory party promised these 4 integrated medical centres, and they would close Thurrock Hospital. The only one open is the one in Corringham. But there seems to be a complete lack of scrutiny and planning by numbers of different people in terms of ensuring that we're in a place to have these centres delivered. Politicians stood up, said that these centres would be delivered, but people of Thurrock have been lied to. There's a pattern here, a pattern of lack of scrutiny in terms of any plans that we seem to want to develop in Thurrock. The financial disaster of this council, in my view, is lack of scrutiny. That in itself has put at jeopardy any capital funding that may have been available for the Tilbury site. There's been poor scrutiny around Staveley Hope train station. There's been poor scrutiny around the development of the A13 and the massive overspend on that. From my point of view, this is a Tory failure as well as a health failure. I will continue to work in partnership with all parties to get the best possible deal for the people of Thurrock. I will work with the portfolio holder and other members of this committee to make sure we get the best possible deal. But I really felt I could not sit back and say nothing today because the people of Thurrock have been conned and lied to. Councillor Piccolo.
Yeah, I'm a bit perturbed about some of the comments you've just recently made in your last statement. A lot of them weren't anything to do at all with health and wellbeing, which I thought this committee was about. I know it's coming up to May, but I think it was more of a political statement than actually anything to do with health and wellbeing. And I must admit that surprised me a bit because I hold you in quite high regard. Some of the things that were said tonight 7 years ago, it wasn't the Conservatives that pushed through the integrated medical centres. It was the NHS. We may have been supportive of it at the time, as so were the other local parties as well. But it wasn't us that pushed them through. Anyway, I'm not going to say any more. I'm just disappointed that I think you possibly used the wrong time to make some of the statements you made out of this meeting. They might have been appropriate, but I don't think they were tonight.
Can I just say I have the utmost respect for you, Councillor Piccolo, and every member of this committee, but I do feel that we have dragged our heels on this for 7 years, and the people of Thurrock will pay the price. Councillor Polly.
And I also I take overview and scrutiny very seriously, and on other committees that I sit on, and up to tonight, this committee, I've always been proud to be a member of HOSC, Corporate Overview and Scrutiny, because I think that is where we come together collaboratively for the best interests of the people of Thurrock. And we can't be an effective scrutiny body if we openly declare our conscious or unconscious bias. It shows a mind that is closed. And I do feel that the comments that you've made tonight, Chair, have left a nasty taste on the scrutiny. When we have witnesses that come forward and have spent, 4 hours in our company, being prepared to be challenged on their role and their work, then to be subject to a statement about things that are not within the remit of this scrutiny committee. I'm disappointed, Chair, I'm sorry, and I needed to put that on record.
I think Kim's clearly said the issue is not political. We got shafted by the NHS. The council getting blamed for it. We clearly need to split the divide. It's NHS's reason why we're not getting IMC as well. Nothing to do with the council, clearly.
I thank you for your comments. I stand by what I say. Councillor Spate.
Yeah, I'm going to spring to the defence of the chair, not because I support his political opinion, but because I believe that he was speaking facts. And the simple fact is, as you know, those people who've known me, I've lived in this borough for 20 years and worked as a journalist in this borough. And I've had these centres rammed down my throat, and every time I've criticised it, I've had politicians criticising me as being an unfair journalist and saying this is all going to happen. So I'm sorry, the truth is, politicians, this has all happened under a particular administration over a number of years, and that is a fact. And it's those politicians that have said it. And if the chair of this meeting, irrespective of what political colour he is going to be criticised for saying facts, then you can forget about overview and scrutiny.
Councillor Fish.
Yeah, just to say that I also support what the Chair said, because we are here to hold people to account. And I think that's a valid comment that he's made in terms of, if you see it in those terms, that's what scrutiny should be doing.
I'd like to move on to the next item. Thank you for your comments, but I want to make it really clear. I want to work.
We're not.
I want to make it clear that I want to work in partnership to get the best result for the people of Thurrock. But I do think there are a number of questions that need to be answered. Can I move on to the next item, please? I'm sorry, William. for holding you up, but can you give us an update on, I think we talked about the GP's report.
Thank you very much. I'll keep this very brief because I'm conscious you will have questions that you want to put to Alex and myself. As the paper sets out, there is a national programme of changing the model of primary care to recognise that the demands placed on primary care at the moment are well beyond its ability to respond to. And as well as growing capacity, we need to change the model in which people access primary care services. We obviously saw during the pandemic the shift to the use of telephone triage, and that change is here to stay in some guise. However, the demands upon primary care have continued to grow. Capacity has continued to grow throughout that period as well. We're seeing more patients in primary care now each week than we have done at any other point. However, we know that there are patients frustrated that they cannot get access to services. The Access Recovery Plan sets out a series of ambitions nationally and locally of how we want to try to address that by introducing that new modern general practice model. And that very much is around taking that totality of demand and trying to triage it in a different way and offer a different range of solutions to your kind of traditional GP, practice nurse, etc., to best respond to patient need. I guess a couple of points I'd just like to pick up on that have been mentioned today. So Rita's obviously talked through integrated neighbourhood teams. In order for those to work successfully, we need to be able to differentiate demand coming through the system. So what is a patient's need when they are presenting to primary care? At the moment, we know it's that kind of rush for 8 o'clock. Everybody calls their practice trying to get to see a GP or somebody within the practice. We need to be able to differentiate that to identify those patients that need that complex care management through INTs versus those who need shorter episodic advice that could come from any healthcare professional. That's fundamentally why we're trying to change the model in which primary care operates. I'm very conscious that this paper is a Mid and South Essex ICB summary of the access plan. We have tried to draw out some of the local Thurrock developments. We are trying to make sure that we are investing resources where we can do around taking into account deprivation factors to say that we want to address inequality. We need to invest more in areas of higher deprivation. And indeed, we have had a number of successful examples of that within primary care itself, such as our Winter Access programme, which is partly weighted towards deprivation. There's also a number of examples at the back end of this paper around how, particularly Alex and her team, are taking forward service developments beyond primary care, but with primary care, to try to improve outcomes for the population. It is very much the start of a programme. We're trying to make significant headway by the end of 2025. However, the reality is the new model of primary care will be here to stay, and we've got to continue to evolve services behind that. So although what's in this paper is something we're trying to deliver over the next 18 months, that work will continue well beyond that period as we develop a new model of accessing primary care services and indeed the NHS.
Thank you, Guy. Your state.
Yeah, just a quick question. I'm interested in self-referral, and you talk about 10 self-referral pathways, which I'm sure means something to you. It doesn't mean a huge amount to me. And then that led me to looking at your modern general practice access model, and it's got call, walk-in, online request, and then you suddenly have captures request in online tool. I sit on another committee, which is housing, where one of the virtually every meeting we ever have, we discuss the fact that a significant number of the population of Thurrock, and it will be an increasing number. People say the silver surfers are going to die away. No, they're not. We're going to get more. It's a fact. And as people suffer more dementia and live longer, we're going to get more and more people needing it. Are you absolutely, confident? It scares the living daylights out of me when I see everything seems to be going online. And I know it starts with call and walk-in, but then it's captured by an online tool. Do you foresee that being problematic in a place like Thurrock?
if I pick up both of those issues, first one around self-referral pathways. So this is, at the moment, and historically, the general practice has been a gateway to NHS services, with the exception of the Minor Injuries Unit and A&E. In the main, patients need to see their GP, be assessed, triaged, and where appropriate, need services beyond that, they get referred by their GP. There are a number of common conditions and presentations where that isn't needed. The value added of seeing the GP is very, very limited, and actually we should be opening up the ability for patients to go directly into those other services. So things like improving access to psychological therapies. Historically, to get access to that service, you would have had to go to general practice, but over the last few years we've encouraged people to identify that as a solution that they can go directly to. One of the things we're trying to do is consolidate all those pathways in a really clear way, because you have to navigate probably now 15, 20 websites to know what's out there for you. If we want patients to genuinely be able to access services easily, you've got to make that route of knowing what's there more straightforward. And so part of this is about how do we build that infrastructure to make it clear and obvious what those choices are and promote those services to the local population. One of the key areas of development we're going to see over the next few months is around community pharmacy, and a number of presentations where community pharmacies will be able to offer interventions that historically they haven't been able to do, and be remunerated for those as an alternative to general practice. And so that's something we're going to work closely with local community pharmacies on, and indeed build a trust and relationship between general practice and community pharmacy, which has moved on quite significantly. In terms of the online tool issue, so I do share concerns. You've got a significant user group of primary care services now who are used to either telephoning or turning up in person to practices, because that's what they've done for 20 years plus. We might say go online, but some people might feel comfortable with that, an awful lot of people don't. What we're trying to do is make sure that there is a common triage process, so that regardless of how you present to general practice, all of those demands are triaged in a consistent way. And so we need to channel that through a route. But what most practices are doing, where they are adopting the new modern general practice model, is that they are effectively offering that same solution regardless of how you present. So if you turn up in person, the receptionist will talk you through the same questions that you would have got online, and fill that form out for you, so it can go into that same triage process. Likewise, if you phone up on the telephone, you might be advised, can you go online and enter the information yourself, or you'll get talked through it with the receptionist, so that data is then captured in the same and consistent way. I think probably over time we will see the proportion of the population that use online tools, the NHS app, etc., to access services will grow. But there will always be that cohort who need something different, be it language barriers, communication difficulties, whatever it might be. They will need an alternative solution. And so one of our roles as the ICB is to support practices to make sure that that solution is there. And indeed, when they're planning to move to a new way of working, making sure they're considering that as part of that process. Thank you.
Councillor Polly.
What concerns me is the different practices, GP practices throughout Thurrock or any sort of ICB area, PCNs, whatever. They're all working under they're under different managements. They have different, and again we come back to the electronic patient records, the systems that they can access. One surgery we have this. We've got these hub scenarios. I mean, I live in Purfleet-on-Thames, and at last full council we had a question from one of the ward members there about a GP service that was actually using this, but for day-to-day appointments. We've got the care navigators now. We can't just have a receptionist. We've got care navigators, and there was there was a suggestion that the GP surgery, you could not make an appointment. You had to go online. You can't phone up at 8 o'clock in the morning. I think the message of this is not being handled well, and we don't like to discuss individual cases, but I have seriously been in the GP practice where somebody has walked in prior to this arrangement, has walked in for a third party, like a relative or something that isn't able to get to practice, possibly not even able to use the phone, tried to make an appointment, has been told by a receptionist that they need to phone up, that they can't take an appointment over the desk. Now, that person has then used their mobile phone and has rung that. I know that's an exception, and I know it sounds like a ludicrous situation, but I'm sure Kim that's not the first time she's heard this, and that is a training issue to do with the counter staff, these care navigators. But I do think that sometimes that the pressure is on them to. We seem to be, with all these alternative pathways. I mean, we're talking about the urgent care, talked about district nurses. I mean, the services that the UCRT team, the urgent care response teams are dealing with are way, and they're operational. They take calls at 8 o'clock tonight. They're still out in the field at 10 o'clock at night, going and prescribing antibiotics or doing, catheter problems and things like that. I just feel that the GPs now don't. We're trying to find all these different ways to not letting the public have access to GPs, and I'm not sure that's what is best serving our population, to be truthful.
So if I pick up the points made there. So I think the communication bit is critical, and so one of the things we've done with some funding we've been able to secure is invest in additional comms and engagement support specific to the primary care access programme, because often comms and engagement support is drawn into managing on the day issues. This is a transformative programme, and if we want to make sure that we're doing it in the right way, we need to put the resource behind it. So we have got some common engagement support that we've recently appointed, and indeed we'll link in with the health watches across Mid and South Essex and various other forums that the Alliance operate within to help do that engagement piece. On the kind of then delivering the message, the care navigation side, so there is a national care navigation programme that's in place to train administrative staff in practice to try to get the best outcomes for the population. So how do you deal with people who traditionally would be expecting to get that appointment on that initial call, who you're actually going to be asking for a lot more information and not actually give them at that point an outcome? You're going to say it will now be triaged by somebody. And so there is a national programme of training to do that. We want to supplement that with a local programme that reflects some of the local pathways that are in place as well, because actually everywhere's slightly different and everywhere has different solutions that can be accessed. So we're in the process of trying to get that training established. I think probably in terms of steering people away from GPs, the reality is there aren't enough GPs in this country to deal with the volume of demand that's coming through primary care now. GPs play a pivotal role in triaging and managing risk and complexity of patients in the community. And we need them to be able to continue to do that. But in order for them to be able to do that, there are some elements of demand on primary care that we need to be able to channel into other routes. Otherwise, you'll simply overwhelm GPs with the total demand coming through the system. So that is part. Yep.
So I'm aware of the time I'm required to actually do an extension. But I only want to do another 15 minutes, but I think that's enough. Everyone's had enough. But if agreed, can we have just another 15 minutes of the meeting? Agreed?
on to carers now.
Do you want to say, Guy?
No, that's
Okay.
Enough?
Sorry?
Are we gonna, 15 minutes going to be enough to take this on the work programme?
Kerry, what do you think?
Well, I'm looking at the report. I mean, obviously it's quite a significant contract, so I would like to pull out key points, but it shouldn't take a lot of time, depending on how many questions you have about it.
Can we do to 10:30, and then if we can get it done quicker, we're covered, and if
Okay.
is that okay?
Some of us have been here on drives home as well.
Sorry?
I am conscious how long some people have been in the building and need to drive home.
Ian, I was talking 15 minutes, so sorry if that is going to make that difference.
I'll go to 10:30, but I'll really try and wind up earlier than that, Ian. Okay. Councillor Fish, did you have another question for Guy?
Just say that I've also spoken to somebody who's been in that situation where they've turned up at the surgery and actually got the phone out in front of them and still didn't get an appointment. But my question to you is, I've been in that queue at 8 o'clock in the morning when you feel desperately ill, you know you need to see the GP on that day, and your heart sinks as you're going through it, and you know that you're not going to get that appointment. So how is my experience going to change under your system?
So yeah, it is a very fair challenge. So the totality of the changes that the new access model is trying to deliver is to try to better ensure that people who need to see the GP that day get to see the GP that day, and that is through a kind of combination of making sure we're using alternatives to general practice where they're suitable, through ensuring that we're actually seeing the demand that comes through, because there are an awful lot of people who probably don't get through to a GP and kind of give up on the phone, or indeed are kind of told to call back tomorrow. So that fundamentally is what the Access Recovery Programme is trying to do, is make sure that people like yourself who do need to see a GP that day have a better chance of seeing the GP that day. Unfortunately, there is no quick fix to that, and it is a multitude of actions that have to happen to try to help that be delivered. Some workforce, some digital, some kind of process issues, engagement issues, etc. Will help make those changes, but that fundamentally is the issue we're trying to solve.
Would the difference be in the menu? When you first phone up, it'd say go online, and we can assess your level of need from that. Is that how it would work?
Yep. So that is an example of how it could work. So I guess one of the things we're also trying to do, for example, with the self-referral pathways, is as people go online and look at their practice website or on the NHS app, and they kind of start to describe their condition, ultimately we want to get to a place where it actually then says, you're presenting with musculoskeletal problems, you can have direct access to a physiotherapy service, would you prefer this instead? And so some of those patients will be automatically channelled off into that direction. But yeah, fundamentally patients will be going online, putting in their kind of symptoms and what they think's wrong, and a variety of other information. Then that will get triaged by the clinical team in the practice, and then sent to various different clinical dispositions.
Okay. I'll just take one last question, and that's from Councillor Tandy.
Yeah, I mean, pre-COVID, when you used to go to the doctors, you could queue up at 8 o'clock, and then it's first come, first served. And after that, obviously, is making a phone call and then getting your appointment. Recently, a few doctors have done face-to-face again, where you just queue up again. Who has that decision?
So it is ultimately the general practice decision. So there's a certain level of requirements and set out in their contracts, but the model in which they deliver care is ultimately down to the practice in the main. However, with the Access programme, so I've worked in primary care for a number of years, and this is the first time where I think the willingness of primary care professionals to do something different is much greater than it's ever been, because I think they feel overwhelmed by the level of demand coming through. They're frustrated that they can't do the right thing for all of their patients because they're only able to deal with X number in a day. And so I think there is a real willingness from primary care to change. As we saw during the pandemic, the movement to telephone triage was quite quickly adopted. We're hoping that through getting GP peers and practice manager champions and other stuff in the practice to kind of push the messages about what we learn, how we would do things differently, kind of that kind of experience of making the change, that we can bring everybody with us on that journey. But ultimately we have got to bring across Mid and South Essex 145 practices on that journey with us.
Okay, thank you very much. I'll watch with interest what's going on, and maybe we can keep a watch on that. So if I could move on, I do apologise. Kerry, if you'd like to present the commissioning report.
Yeah, so I'll keep it short because you've all had the report, but I'll just pull out some very key points. So the purpose of bringing this today is to get your support for going out to tender for the domiciliary care contract for adult social care. The existing contract expires end of March 2025, but obviously due to the kind of the size of the contract and the fragility of the marketplace, we need that kind of long run in to make sure that everything goes smoothly, particularly should we get a number of new providers as well. A couple of points just to pull out is that this is our opportunity to really change the model of domiciliary care. So you've heard a lot tonight about Better Care Together Thurrock and the integrated care strategy that we've brought to this committee previously, and Ian's delivered certain presentations on as well. Chapter 8 of that strategy deals with developing a new model of home care and support in the home. So what we'll be doing with this, with going out for this tender process, is actually building that model into the specification for this contract and working with those providers, some will be existing, some could be new providers, over the life of the contract to shift them from the current model to that new model. It is quite a significant change, so we're not expecting radical change on day one. It will take a while to work with those providers, and that's one of the reasons we've suggested that the contract is the lifetime of the contract is 10 years, because we need to give providers sufficient time to develop, and also it gives them kind of sufficient time to invest in that model of care as well. Some facts in the report. Obviously, we deliver about 8,900 hours a week of home care, and that's developed or increased significantly over the last few years. We do have some in-house provision as part of that, but we do have to have a provider of last. I can't remember the R. Resort, thank you. Just should kind of any contracts fail, and we have had that in the past where we've had one or two contracts either failing or handed back, so that will continue. The significance of that kind of in-house resource as well is the provision of specialist re-ailment support as well, so people coming out of hospital who need some support and that can be re-abled towards better kind of or greater independence and mobility, etc. So that will remain. The contract will also include an element of out of hours care for those people that have obviously some care needs from 11 p.m. at night until approximately 7 p.m. in the morning, and that consists of 3 runs, but one of those is kind of paid for by the NHS. So that's approximately £200,000 a year, so quite a small element. The cost of the contract over the 10 years is about 114 or just over 114 million, and Appendix 5 sets out exactly kind of what the inflationary amounts and also kind of incorporating demand growth looks like in terms of that amount and how that's put together. I don't think I'm going to say much more because it's in the report, and obviously time is of the essence. But obviously, if you've got any questions or you want me to go into more detail about this at another time, I'm more than happy to do so.
Councillor Spate.
Yeah, just quick. Firstly, thank you for the map. It's one of the most fascinating things I've seen. And it worries me, Terry, when you and I look at our ward out, the intensity of people in care in Stamford is quite frightening, and I'll be joining them soon. But I'm naturally inclined to think of option one, play it safe. Given everything that's gone on in Thurrock, play it safe always seems like a good card. But I can see why you're going for option two. Are you really that convinced, and I suppose I'm looking at Ian here, because, you're really that convinced it will make that fundamental difference in getting better staff longer term?
I don't think doing the same as we're doing now is playing it safe, actually. I think it's the opposite. I think for those that work in domiciliary care, and we've probably kind of spoken a lot about it, is the market is extremely fragile. And if we don't do something, then we're going to end up kind of just paying more and more, and actually quality is going to be really decreasing. The new contract won't change anything day one, so there'll be no change. We'll go out, but it's around working with providers to do something different. And we believe, having worked with our own in-house pilot called Wellbeing teams, that there are a number of and other kind of authorities and areas have done it as well. The evidence is that it does make a difference, and because it's done in locality, it enables those kind of providers to be part of that locality network as well. So there are lots of kind of advantages in terms of value, quality, and doing things differently. But obviously, it's a significant change. But the risk is low because actually we work with providers, but day one it will be the same as it is now.
Thank you, and I support it.
Councillor Fish.
Yeah, I just think this is the latest in a long line of brilliant, innovative projects that our social care department has come up with. So, well done.
Councillor Polly.
On page 49 of the report at 2.13, improving transfer of care between hospital and community is a priority for government and health and social care systems. In view of our much debated longer item earlier, presumably funding, part of the funding from this is again through the ICB or the integrated care. Who integrated care partnership? I mean, who picks up that tab, and how do we make sure that that's not a movable feast if we're talking about a 10-year commitment? Thank you.
Obviously, we are responsible for covering the costs of anyone that needs or is eligible for social care. So that, albeit whether that's discharge from hospital, whether it's actually an inquiry that's coming through the community, we pick it up. We've been very, I think, very lucky to retain our hospital social work team that's based at Basildon, and they retain very good relationships. Yeah, so they're linked with the integrated discharge team, and we've decided to keep that team because we think actually it gives us more of oversight over what's happening, and just making sure that we are controlling what, for our residents, what's happening to them once they need discharge. And it's also worth saying we've got a very good contracts and brokerage team who very robustly manage kind of those discharges in terms of getting the right provision for them, and actually making sure that the handover is very good. And our delayed discharges have always been very low as a result of that as well.
A very good report. Thank you very much. If I can move on to asking that HOS support the tender for domiciliary care services to meet statutory requirements under the Care Act 2014. This includes both core domiciliary care services, reablement and out-of-hours service. Yes?
Agreed.
Part 2 is that HOS support the recommendations to delegate the award of contract to the Executive Director for Adult Housing and Health in consultation with the portfolio holder for Health, Adult Health, Community and Public Protection. So agreed?
Agreed.
Agreed. Right. Okay, I know we've got the work plan on the agenda, but I think how late it is, I think I'd like to review that and do...
Officers can go now, can't they?
Yeah, officers can go now if you want to go. Thank you, Councillor Paul. Right.
We can do that outside the meeting. We can pick it up tomorrow.
I'll pick it up tomorrow, so I will call the meeting to a close. Many thanks.